People, good morning and welcome to the September meeting of the Oregon Health Policy Board. I'm gonna give people a moment to get their audio connected and join the room, but would like to welcome everyone. Um, do a little housekeeping agenda items and then we'll get into the bulk of the meeting. Kirsten, and nice to see everyone. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, comments can be sent via Zoom chat to the meeting host co-host. If you have a supporting resource link to share with the meeting participants regarding an agenda item currently being discussed, share that link with the meeting host or co-host, and they'll share that with attendees. And all materials for today's meeting are available in the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. And the link, there it is in the chat. So I'll turn it over to Tara for our roll call.
Great, thank you. Good morning, everyone. Melina Moran.
Yes, present, and I will be off camera today.
Great, thank you for letting us know. Bill Kramer.
Present.
Thank you. Brenda Johnson.
Present.
Kirsten Isaacson.
Present.
Dr. Hemmings.
Here.
And Dr. Hemmings, you will be leaving around 11 a.m. this morning, correct?
Yes, that's correct.
Great, thank you. Tony German.
Morning, everyone. Present.
Peter Starkey. I believe Peter shared that he'll be in and out this meeting. I know he will attend the hour for the budget presentation and vote, but looks like Peter is not with us at this moment, but we do have 6 of 7 members for quorum.
Great, thank you. We'll try to note when he is on so everybody knows we have full board present. I'll turn it over for this month's reading of the health equity definition to Tony.
Good morning again, everybody. So Oregon's health equity definition. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices.
Thank you for centering
Thank you for centering us.
Definition, Tony. I'll do a quick review of the agenda and then we'll dive into business. So topics we'll cover in today's meeting. We have a little bit of board business followed by OHA updates, OHA Behavioral Health Division updates, and then public comment. We have the Healthcare Provider Incentive Program budget allocation proposal for the next biennium. The HICMO, or the Healthcare Market Oversight Program, we have some time for public comments related to that program and framework. And then we have some closing comments and we'll adjourn. So before we begin today's meeting, I want to remind all board members of our obligation to disclose any actual or potential conflicts of interest. Upon reviewing today's agenda, if you have a financial interest, professional affiliation, or any other relationship that could reasonably be perceived as influencing your decisions or participation in today's discussions, please take a moment to share it for the record. And as a reminder, you should share actual or potential conflicts of interest. And your transparency really helps ensure the integrity of our work and maintains public trust. So would any members like to share an actual or potential conflict of interest at this time? Okay. Then we will move on to voting on the August draft OHPB meeting minutes. The draft meeting minutes are numbered as attachment number 1 in today's packet. Is there a motion to approve the draft OHPB meeting minutes from our August 5th meeting?
This is
This
Brenda.
is Tony German. Oh, go ahead, Brenda.
Sorry, so moved.
Second, Tony German.
Thank you, Brenda, for moving it. Thank you, Tony, for seconding. Tara, will you do a roll call, please?
Yes, I will. Dr. Hemmings,
I was not there, so I abstain.
okay, thank you. Brenda Johnson,
Approved.
Kirsten Isaacson,
Approve.
Tony German,
Approve.
Bill Kramer,
Approve.
Melina Moran.
Approve.
Okay, we know, I'll just check, but Peter Starkey, are you present? I don't believe so, but we have 5 of 7 members that approve, so the minutes are passed.
Great, thank you. We only have a small amount of board business before we move on to hearing from Claire at OHA. I do want to highlight that 2 candidates have been recommended by the governor to the Senate Health Committee for OHPB membership. The 2 candidates are Aaron Green and Aaron Hines and Hayden Rookley. The Senate will review their candidacy and vote on their appointment in late September. And if everything goes well, we hope that Aaron and Hayden will join us for our October retreat. There's Tara can put in the chat a link to the governor's press release. And with these new members, OHPB will still have 1 non-healthcare seat vacancy. So if you're interested to become a member or know someone who would be interested, please read the membership application and apply through Workday. And those links will also be put in the chat. So look forward to having a fuller board shortly. Claire, I see you coming off camera. Good morning. Claire Pierce-Roble, Director of OHA's Health Policy and Analytics Division, joining us this morning to provide agency updates. Thank you for being with us this morning, Claire. Begin when you're ready.
Thanks so much, Kirsten, and good morning, board members and everyone else. I am happy to be with you today, and I just wanted to give an update on a few different things that are impacting Oregon and OHA specifically related to federal changes and interactions, and then also wanted to share some updates around CCO rates. So this past month has been another one that brought several changes to federal policy that directly impact our health landscape. Those have included things like tighter restrictions on COVID vaccine formulation and ongoing interactions with CMS regarding data audits. These are updates that affect coverage and providers and the people we serve. And so I'm happy to provide some updates on what we're doing and give an indication of where more information will be forthcoming. So the first I just wanted to give a quick update on was the most, I would say, highest profile development around the creation of the Western Health Alliance. In response to some of the alarming federal confusion and dysfunction around vaccines, particularly the COVID-19 vaccine. The governors of Oregon, along with California, Washington, and Hawaii, created the Health Alliance that aims to increase operational alignment, speed, sharing of information, and provide those that we serve with health guidance backed by science and clinical expertise. So this is an alliance that is in the early stages. The organization and priority setting for that alliance is currently underway, but is moving to meet this moment with urgency. So through the new, what's being referred to as the Western Health Alliance and by association OHA, the organization is moving quickly to address the first concern, which is the availability and coverage of this year's COVID-19 vaccine. Last week, we heard from Oregonians that due to the federal policy changes and the approval delays by ACIP, pharmacies are now requiring a prescription for COVID-19 and may not be appropriately billing insurance for the cost, including the Oregon Health Plan. So while we await the ACIP's expected recommendations on September 18th and 19th, OHA is working closely with the governor's office and the Oregon Board of Pharmacy to review our options for maintaining access to this vaccine and assisting concerned patients and providers with information, again, as we are navigating through this challenging period and building a structure that can help us to better respond in lieu of federal leadership in this particular area. Additionally, outside of vaccines, we're continuing to address the ongoing data asks from CMS regarding Oregon Health Plan member data. CMS has repeatedly declined to state in writing that this data will not be used for immigration enforcement. CMS did threaten OHA with a $50 million fine if we do not audit our data and submit data to them. We have not at this time provided them with any new data beyond the standard monthly reports and have not provided data regarding immigration status. So really no new updates, but just wanted to provide that update here as we're continuing to engage with CMS on this front as well. And then I think one other area I was asked to speak to was regarding the revised HHS interpretation of the Personal Responsibility and Work Opportunity Reconciliation Act, sometimes referred to as PROWORA, if that's an acronym that you can pronounce. Oregon DOJ joined 20 other states in suing the federal government over that new interpretation, which would impact Oregon's Title X program, and asked the court to declare that that new interpretation is unlawful, to halt HHS's implementation through preliminary and permanent injunctions, and also asked to vacate the rules and prevent the federal government from using PROWORA as a pretext to dismantle core safety net programs in the future. In late July, and just as a reminder, I think we gave this update last month, the federal government did agree to extend the date of non-enforcement. And in August, we also submitted formal comments to HHS opposing HHS's interpretation. So this again is a place where we are waiting to see how this plays out in the courts, but have made our position known in various ways. And then finally, on the federal front, I would note that we've discussed previously that OHA and ODHS have established a coordinated group to assess HR1 impacts. So this is the One Big Beautiful Bill Act, or House Reconciliation Bill 1. We are anticipating a number of changes in the coming years. Some have already gone into effect. This will be a very large lift for the state to take on the various administrative requirements that this law passes to states, along with the cost and the impacts to patients, providers, and coverage across the board. And so we are taking a coordinated effort to look at that and plan for future years. I'll continue to bring updates to this group as we have more. The group will also be assisting in communicating these changes with community and providing opportunities for ongoing community engagement as it relates to specific policy areas, including implementation of Medicaid work requirements, changes to eligibility, and other funding impacts. So additionally, more information to come there, but we are currently in a planning stage. I would say just this has been a challenging time, I think, for OHA and our teams, but our staff are really working diligently with partners to address concerns as we hear them, to be able to analyze impacts and really continue to center the people that we serve and meeting the needs of the moment here. So just a couple other things to speak to. We are anticipating CMS rules that would impact gender affirming care access. Specifically, there is a proposed rule under review with the Office of Management and Budget that would change conditions of Medicare and Medicaid participation to ban specific gender affirming care services for people under 19 and restrict funding for hospitals where those services are provided under, again, what's known as the conditions of participation rule. That proposed rule is not yet public. Just the title of it is available under the OMB website, but we expect, given the timing, that those proposed rules could become public in the next couple of months. We are obviously hearing concerns from providers and patients about the impacts of these changes and the need for a safety net to ensure the continuity of care. This is something that we have been tracking closely since the decision by some systems to stop providing certain gender affirming procedures for people under 19 this past month. We've been conducting ongoing community engagement through in-person listening sessions, co-hosted with community partners and clinics across the state in central, southern, and eastern Oregon and on the Oregon coast. Our team has continued virtual listening sessions planned for this fall. So our focus at this time has been listening to community and continuing to coordinate with our partners across the state to address those concerns and see what can be done either directly or in partnership with the Oregon DOJ. Finally, I did want to share a few things about CCO rates. So Oregon is, OHA is currently working with coordinated care organizations to negotiate rates and contracts for 2026. The agency's primary goals during these discussions have been to ensure quality care for OHP members and to be good stewards of state funds while working with CCOs to be able to achieve these two outcomes. As is probably no surprise, numerous changes at the federal level are creating a much different healthcare landscape as we go into 2026. We are expecting new requirements, more paperwork, more administrative burden, and fewer funds to work with, much fewer funds to work with. So we are acknowledging that this is a really tough starting place. Like every corner of healthcare right now, CCOs are facing many challenges. And throughout our discussions, OHA has listened to requests from CCOs regarding rates and contracts for 2026. I will just say we've gone really above and beyond to address CCO needs while also minimizing disruption for OHP members. While acknowledging the resources needed to deliver those services to OHP members and aiming to be good stewards of state dollars, OHA proposed an increase to CCO rates. One of the central parts of that proposal is to reduce administrative burden and reporting requirements so that both CCOs and OHA can spend more time improving care for members. Last week, OHA sent a proposal to CCOs that moves CCO rates to match the rising costs of healthcare based on proposing to increase CCO rates based on additional data that's been received since early August. We've seen that expenditures per member grew by more than 10% between 2023 and 2024, which is in line with overall healthcare cost trends that we've seen in all sectors. OHA's proposal would put capitation rates from a 6.8% statewide impact to a 10.2% rate. So we are, as an agency, continuing to meet with CCOs in the coming weeks, and we'll continue to work collaboratively to identify solutions that meet the stated goals and specifics outlined in CCO contracts to best serve OHP members. So I would just say that we recognize that cost growth changes like this and trends are not sustainable. So this is a start rather than an end of what's continued to be an ongoing, intended to be an ongoing dialogue about ensuring the sustainability of the Medicaid program amid the unprecedented fiscal and policy constraints. So I will happy to circle back with additional details when there's information to share on this or any of the other updates I provided today. But I will stop there and turn it back over to Kirsten.
Great. Thank you, Claire. Media updates and lots of important topics in there. I'd like to see if board members have any follow-up questions on these, what was raised, or any other topics they'd like to hear about. Go ahead, Brenda.
Thank you so much, Clara. As Kirsten mentioned, there's a lot in your update and many, many details that fall underneath any one of those topics. Um, two questions for you. Where might the public find additional information if they're interested in any one of the areas that you covered? And then my second question is if you could spend just a moment or two on updates for the Rural Health Transformation Program and how OHA is approaching that. Thank you.
Absolutely. So I will start with the first. Our I would say one-stop shop on most of what I just shared continues to be our OHA website on federal policy changes and updates. So we continue to keep that updated with information, actionable information about changes both to coverage and interactions with the federal government. So I will ask if Tara might include that link in the chat so folks have easy access. I think on the changes I mentioned regarding CCO rates, those will be communicated by the Medicaid program through various channels to members. On the Rural Health Transformation Fund, this is just for background for everyone. This is a component of HR 1 authorized and appropriated $50 billion for 5 years. It's a one-time program. Half of those funds will be split evenly among 50 states, and the other half will be distributed based on CMS discretion and a number of criteria some criteria that are named in the HR 1 statute and others that have yet to be defined. We are awaiting a notice of funding opportunity from CMS that will explain what those conditions of award will be and how Oregon can apply for the funding. As we're awaiting that information, we have engaged and requested public comment to help us inform and design our program application. That link I will also make sure is shared in the chat. We have just extended that opportunity to provide comment through the end of this week, although we've already had really robust participation and response. And that information will, again, help us with developing an application once the notice of funding opportunity is available. I think a couple of points here. One, there is the funding actually starts federal fiscal year 2026 and goes through for 5 years. Federal fiscal year 2026 starts on October 1st. We are not expecting to apply until at least November and receive notice of award by the end of this year, meaning those funds won't start to flow until early 2026. So we are planning and kind of requesting information about what might be projects that could be or types of projects that could be funded in an earlier phase that are ready, clearly defined, and recognizing that, again, we have a short window. We will have a shorter window the first year for program expenditures. And we are also asking for ideas, again, concepts that could help to shape an application for this federal funding that would require a longer planning period and might include things that would be facilitated by regional collaboratives or partnerships. And that could, again, address some of the activities that are fundable under the statute. So we're kind of asking for feedback in those two areas to help shape the application, but welcome anything else. And of course, more information will be known about exactly how these funds will be available once that notice of funding opportunity is released, expected sometime this month.
Thank you, Claire. Bill, I see your hand up, and then we'll go to Tony.
Great. Thank you, Claire, for your very clear and thorough update. I have two related questions related to the good work that Oregon's been doing with the Western States Alliance. On vaccines, I understand that several other states have issued a standing order, in effect, a prescription for all state residents in order to ensure access to the COVID vaccine. In your update and what I've read, I'm not aware if Oregon has done that yet. And if not, is OHA considering taking a similar step?
Thanks for that question, Bill. I will refer questions on that to the governor's office, and we'll make sure we get a response. I think those would be steps that would need to be taken by the Board of Pharmacy, so outside of OHA's jurisdiction. Again, this is, I would say, something that we are looking at actively and internally looking at what strategies we have at OHA through our administrative policy levers to improve access to vaccines, and sharing information about where where there's confusion or where we're seeing barriers, so that other state agencies can take steps as appropriate. But I can share that question directly with the governor's office, who's leading on this initiative.
Great. Thanks, Claire. And just a follow-up question on the Western States Alliance. I really applaud the action that the state has taken. I think there's a need, though, if possible, to do more. And I'm hoping that that more could be done with this alliance. For example, I'm concerned that the destruction of the Centers for Disease Control will make any federal data, for example, on communicable diseases, to be unreliable. And it would seem to me that a joint effort, in addition to the effort on vaccine guidelines, potential collaboration, for example, to joint tracking of COVID and other infectious diseases and public reporting, and I'm sure there are many others, would be the alliance could be could play a really important role in that. I don't know if you want to comment on that. I'm not asking a question of exactly what's going on, but if you could, I would like to express an interest in that and an encouragement for the state to pursue that.
Thank you, Bill. I will certainly pass that on as well. I think at this stage, the states that are participating in the alliance are working together to set shared vision and goals, and so I think this is an important place to raise that during this initial phase.
Great, thanks.
Penny, go ahead.
Well, thank you, Claire, and what tumultuous times we're living in. So really appreciate the importance of good quality information. And I think OHA is really doing a phenomenal job with that. And I think the website and dissemination of that information. And I think what we're seeing federal changes with regard to the CDC and the undermining scientific integrity and in many different respects is quite alarming. So Bill really covered a number of my questions. I think in regard to the Health Alliance, I really support that effort. Also would encourage, the comments that Bill shared with regard to attention to vaccine policy, but perhaps some further bridges and alliances that can be made to support how we deliver good quality care on this West Coast is where we find ourselves and what's changing with policy. And I just really wanted to applaud the recognition, the concern of the personal responsibility of the PR WARA. And I think that is a really important piece of information for us to stay attentive to. Again, working in a community health clinic, that would really be a setting that would be quite detrimental should that policy proceed, which would, by extension, really lead to poorer health for the broad community, not just those of immigrants in our nation. So really appreciate the state taking that stance, Oregon DOJ. So just really important work. So thank you.
Certainly agree with you, Tony, about the broader implications. Okay. Claire, thank you for the updates. Thank you for representing the hard work of the agency and navigating these changes in times. We look forward to more information and collaboration with you.
Thank you.
Right. And with that, up next, we have OHA's Behavioral Health Division leadership team with us today to present on two behavioral health. Well, OHPB has two behavioral health priority work goals that we've asked OHA's Behavioral Health Division team to come provide input on. So the first goal is our goal to provide input and support on how key performance indicators in OHA's strategic plan are reached. And the second is related to OHPB's commitment to learn about the committee and board structure of the Behavioral Health Division as we think about how we navigate that space. So we welcome Ebony, Krista, John, and Lena to our meeting. We'll pull up your slides and you can begin whenever you're ready. And I see all of you beautifully here.
Can everyone hear me okay?
Oh, yes. Now we can hear you.
Okay. I'm having technical difficulties, and so I'm having to use my phone for audio. So, all right, let's go to the next slide. First off, I want to appreciate and thank the board for this opportunity to provide some updates and step into discussion for further guidance and recommendations. So today, we'll start with just a quick level set of the overview again of what we do in the Behavioral Health Division, and then we'll go into updates specific to the strategic plan around transforming behavioral health, and really speaking to kind of just, you know, where we're at with the various metrics or KPIs, if you will. Then again, we want to do a level set too to kind of really give a snapshot of just, you know, the various boards, committees, and commissions that really influence and shape the work that we do as a division to support the behavioral health system. And then we'll provide the updates specific to the Behavioral Health Metrics Committee. So next slide, please. Next slide. All right, so this is just a visual that really kind of depicts what we do and what we focus on and what we prioritize as a division. Oregon's Behavioral Health Division works to support Oregonians to achieve the mission of OHA in terms of achieving physical, mental health, and social well-being. We focus on preventing mental health, substance use, and gambling disorder through our continuum of care, from prevention, early intervention, and then access to services, treatment, and support. Largely, the scope of the work that we do within the division really focuses on, number one, going from left to right in the visual, looking at how do we drive support, advance policy, really rooted in what we do as a division within OHA in terms of our oversight and regulatory responsibilities. And within that, one of our core priorities and responsibility also is to assure quality of services and assure accountability standards in, you know, what we oversee, fund, and support as a division. We also work to make sure that we are sustaining the continuum of care across the lifespan, and really making sure that as needs across the state evolve, that our system is evolving to meet kind of the various needs that Oregonians present specific to behavioral health. And so really wanting to make sure that we have access and capacity and appropriate services to meet the various needs, whether someone is in crisis, whether someone is seeking services or needs services in the realm of, you know, the serious mental illness, or whether we need to have tailored services for children, youth, and families, just as an example. We also want to make sure, and we really work to assure that what we do from policy to practice to funding is really driven by the voice of those with lived experience, by community, by key partners, in addition to then, you know, the various councils, advisory bodies, and boards that also help inform our work. And then we also have the responsibility of making sure that we are maintaining a workforce and a system infrastructure to better meet the needs of all Oregonians that rely on our system. And so just always want to start with a level set around what we do as a division within the Oregon Health Authority. Next slide. So we'll go into the providing updates specific to transforming behavioral health pillar within the Oregon strategic plan. So next slide. And so there's a few parts of this update. We'll start with a quick overview of the OHA strategic plan structure and the types of measures associated with the OHA strategic plan. The OHA strategic plan is rooted in the health equity definition, and it's meant to align with OHA's goal of eliminating health inequities by 2030. As y'all are familiar, there are 5 pillars that were identified, which are crucial to supporting the 2030 goal. And today we're going to focus on transforming behavioral health, and that's what much of the Behavioral Health Division focuses on, but also in tandem, we have the concentric circle to then supporting the other 4 goals specific to the strategic plan. Next slide, please. Want to also do a level set, just because, I think that when we think about key performance indicators, the way that that translates to the OHA strategic plan is through the various measures. We have global measures, we have outcome measures, and we have process measures. Global measures, these are measures that are meant to be holistically representative of the behavioral health efforts in Oregon. The outcome measures are tied to each pillar strategy to show improvement at the strategy level. And then we have process measures that are tied to the actions of each strategy within a pillar to show progress and improvement. And so wanted to just kind of do that level set as we start to go further into updates around where we're at. Next slide. Transforming Behavioral Health Pillar has 5 guiding strategies. I spoke to, the clarification of KPIs, but again, the KPIs are indicated or noted in our various measures. Again, each strategy has 1 outcome measure, and then each strategy has key actions. Each strategy has 3 key actions associated with it, and then I want to say this just because it starts to get a little confusing, so I really want to do a level set. And then each action again has a minimum of 1 associated process measure, and oftentimes more. Okay, let's go to next slide. This provides just kind of a visual snapshot of just what the timelines and phases have been specific to the development of the various measures. Global measures were selected by our OHA director, Dr. Hoppy, and those were put forward in November of 2024. The data for the public dashboard was submitted for inclusion and transparency in December of 2024. When we look at the specific strategy outcome measures, you'll see in the visual that drafts were submitted to OHA Director's Office in December of 2024 and then approved thereafter in December of 2024. And then the data for a public dashboard was submitted for inclusion and transparency also in December of 2024. And the public dashboard went live in January of this year, so in January of 2025. And as we delve into this presentation, we're actually going to cover the specifics of the various measures as we move forward. But just in terms of timing, you'll see that, again, global measures are completed, the strategy outcome measures are completed, the dashboard is up and running, and then you'll see in terms of our process measures, just where we're in progress, where there's pre-work, and or where we still have work to begin. And then there's the associated kind of dates of completion and finalization, where then we'll get approval to then be able to codify and publish and move forward with. Next slide. Also want to note that we are actively working to ensure that draft process measures are in alignment also with the federal response team and just, the federal implications. There are many unknowns in terms of what we're having to navigate in terms of the federal landscape. And I want to acknowledge that there may be future impacts on measures selected as things continue to evolve. But again, want to make sure that we're letting y'all know, these are things that we're thinking about as we're continuing to finalize the proposed process measures. So really making sure that we're pivoting to ensure alignment, to make sure that we are sustaining a system to meet the needs of Oregonians due to the federal implications. Really also wanting to make sure that we're not losing sight and really being able to do our due diligence around equity impacts, in addition to, again, just making sure that there's enough responsiveness and accountability to be nimble and agile to make adjustments where we're going to have to based on things that we're currently not anticipating. Next slide, please. All right, so now we'll go into working and kind of previewing the specifics around the global measure and outcome measures. Next slide. So also want to note that many of the data sources for the outcome measures either are used and come from an annual or biannually perspective. Unknowns if any of the measures will be impacted by the federal changes to data reporting are again something that we're trying to make sure that we are creating space for and being able to update in real time. And again, we know that we will be coming before you all at a regular cadence to provide updates on transforming behavioral health outcome measures as we move forward. Next slide, please. All right. As I spoke to earlier, Dr. Hossie identified our global measures. These global measures uses data from the Oregon Behavioral Health Risk Factor Surveillance System from one of the questions in the quality of life section. And then also looks at self-reported and identified number of poor mental health days in the last month. And then also within your slide deck, you'll be able to click the link to then actually go to the dashboard to actually see progress towards that. Next slide. For Global Measure 2, this again was also identified by Dr. Hossie, and it uses data from the Oregon, I won't try to pronounce the acronym, the State Unintentional Drug Overdose Reporting System. And this measure emphasizes work being done to address the fentanyl or opiate overdose crisis. And again, you'll see that you'll have a link to the dashboard within your slides. Next slide, please. And now I will hand it over to Dr. Jones to go over this next section specific to strategies.
Thank you so much, Ebony, and good morning, everyone. I hope you can hear me. I'm also on my phone for audio, also having technical difficulties. I'm Krista Jones, and I am the Deputy Director for Behavioral Health, and my area of focus is called Service Delivery. So I'm going to be going over some of the strategies over the next few slides. As you can see here, there are 5 strategies that Behavioral Health Division is driving to support the transformation of the Oregon behavioral health system. And each of these strategies has an outcome measure, which I'm going to talk about in the following slides. The next slide, please. I'm not going to go over all the details that are on the slide because y'all have them here, and I think that the slides were also sent to y'all. But I'm going to share a couple points for each of them, and then there also is going to be a summary later. So for the outcome measure for strategy 1 about connecting all Oregonians to care, the data set that was being used for this measure comes from SAMHSA, the National Survey on Drug Use and Health, which is the NSDUH. And unfortunately, they had a team of 17 individuals that was dedicated to this survey that has been really longstanding. those 17 people, unfortunately, were terminated abruptly by the current federal administration. And we were expecting the data from 2025, I'm sorry, from 23 and 24 to be published in 25, but unfortunately, we don't know the status of that right now. And so that is something that we are, constantly monitoring to ensure that we get the data that we need. Next slide, please. For strategy 2, which is bolstering the behavioral health workforce, the data for this outcome measure uses the healthcare workforce reporting data, and this comes in from licensed providers. So that is steady for us. Next slide, please. For strategy number 3, excuse me, this measure is going to utilize the health-related social needs service utilization as the data becomes available. And if you haven't checked out the dashboard, I really encourage you to do so. It's very comprehensive and easy to navigate, and I believe it's in the chat. Next slide, please. Finally, for strategy 4, this is improving transparency and accountability. We're going to be at the end, when we meet our goal, we will have published 9 dashboards, and we are well on our way to do that. We really want to uplift transparency and accountability through data sharing and reporting. And so we really look forward to having all of those dashboards published so that we can engage and communicate with the community in this different way. So with that, I will hand it over to Linnea.
Good morning, Dr. Linnea Lindsay. I am one of the other deputies. Thanks, Dr. Jones. Next slide, please. So this is the process measures update to kind of go back to the next slide, please, to go back to the triangle that you were seeing, the pillar, the strategy, and the action. These are the actions, and they probably most clearly are what people would talk about as KPIs or key performance indicators, but we don't use that term in our strategic plan. They're called process measures. And if you were reviewing the timeline, you would have noted that these are now in development. They're not yet approved, but we're working towards them. So they are evolving, and that we want to ensure that they're all aligned with the evolving OHA policies and procedures. In August, last month, the pilot process of draft plan for measure review was begun, and up to 5 process measures can be due at the end of each month for OHA strategic plan sponsors to review beginning in September. Next slide, please. So this is the timeline. Each pillar submitted at least 1 process measure, and that's not just our pillar, but every one of the 5 pillars submitted at least 1 process measure on August 25th. For review. And on just last week, the first pilot for the OHA strategic plan sponsors feedback on process measures began. This review will happen through this month, and then up to on the 30th of this month, we'll submit up to 5 more process measures for review. So if you're going through the recollection, if we have 5 strategies and we have 3 process, we have up to 15 measures. Next slide. So 2 measures were submitted from behavioral health for feedback in that August 25th submission. We have 9 measures that are ready, and we will submit 2 to 5 of them based on the feedback of how this process is unfolding and rolling. And then we still have 4 measures that we're needing to get to identifying where the data will come from to make sure that it's in alignment. Next slide. So again, we're making all efforts to collaborate across the system and make sure that our behavioral health measure selection really builds on this strategic plan, and that we're utilizing all the feedback that we get from our boards, our committees, our commissions to make sure that there's insight into what really are the measurables that people are looking for that are substantial, not just to measure, but to measure for improvement and for a substantial impact, including future collaboration with the Behavioral Health Committee for feedback on the recommendations on the 2027 measures that will build on the current 24-27 measures. And next slide. I will hand it off to my colleague, Dr. John Collins. Thank you.
Thanks. Hi, everyone. John Collins. I am the third deputy for the Behavioral Health Division in charge of operations and strategies, which includes things like our behavioral health investments, our workforce development, contracts, and just general operations. So as Dr. Lindsay, excuse me, gave me a nice segue into the behavioral health committees, boards, and commissions. And we operate within a pretty broad ecosystem of various types of advisors, boards, committees, etc. And our staff have a number of different relationships with them, including in some cases leading them, in other cases participating as a voting member of a particular group, and in other cases we are working to support the different committees and commissions that we're involved with. I'm going to be going through a couple slides that try and give you the broad outline of that, and so that you have a better sense for the involvement and the input that we get at the Behavioral Health Division as we look to define policy, rules, and regulations. Next slide, please. So this slide is really meant to give you a broad overlay of what the Oregon Health Authority itself has to interact with in terms of a number of the different groups. It doesn't obviously outline every single one of them, but it gives you a good idea of many of them. And within that, the Behavioral Health Division, obviously being a part of the Health Authority, has interactions with many of these as well. Some of them are very direct, such as with the coordinated care organizations who provide a bulk of the behavioral health services in the community, as well as the community mental health programs, which provide the other big bulk of services, and mainly, and those two actually even work together. So, and then we have advisory councils, such as the System of Care Advisory Council and the Alcohol and Drug Policy Commission, which seek to advise us and help us to develop policy and direction for behavioral health services. And then we have many of our funding partners, such as our federal partners and obviously the legislators that we work with. And then obviously there's the Health Policy Board as well, providing direction to OHA and therefore to the Behavioral Health Division as part of that. But then if you can move on to the next slide, there are many more commissions, councils, and work groups that work directly with the Behavioral Health Division. There's quite a few under the service delivery area that Krista, or Dr. Jones, and her team have to work with, including some on specific types of services, such as assertive community treatment, to broader planning, such as the Addictions and Mental Health Planning and Advisory Council, which advises us on how we utilize our mental health block grant that we receive from the Substance Abuse Mental Health Services Administration at the federal level. We have other groups that focus on some of our services that do not make up the bulk of our funding, but are very important services to keep moving forward, such as our Problem Gambling Services Multicultural Advisory Committee. So again, a wide variety of groups and types of topics that we're advised on. If you can go on to the next slide. Aside from the service area, we also work with several different other areas of interest, such as For Measure 110, we have the executive director, who's part of the behavioral health division, but she and her staff work directly with the Oversight and Accountability Council, which have play a very strong role in who the behavioral health regional coordination centers are, the networks are, the Burns. And then we have equity and community partnerships that are defined by the Behavioral Health Committee, our Oregon Consumer Advisory Council. And then we have other groups advising us on some of our strategic things that we're trying to address, such as workforce and investments. Next slide. All right. And I'm going to turn it back over, I think, to Dr. Lindsay.
Thanks. Thank you, Dr. John. Well, we don't ever call each other doctors. That's Dr. Collins.
Dr. John's fine.
So one of the requests for presentation today was to have a closer look at what we're doing with the Behavioral Health Committee, which was a committee stood up by, obviously, the policy board. So next slide, please. So this back to House Bill 2086 that established the Behavioral Health Committee, just level setting around what some of the outlines and goals were here to set up some of the quality metrics for behavioral health services provided by CCOs, providers, counties, and other government entities, and to develop some incentives to improve the quality of behavioral health care. And the quality and incentives are designed to make sure that we're looking at the integration of physical and behavioral health, providing timely access to behavioral health care, ensuring individuals are supported in the least restrictive environment that meets their behavioral health needs, reducing hospitalization, and reducing overdoses. So again, just level setting with the Behavioral Health Committee. Next slide, please. So here is kind of looking at what the opportunities are for the Behavioral Health Committee. It's not March, but I guess we have some buckets of opportunity here. So one is to really help strengthen the existing measures and supports. In 2025, we've been working to lay the foundation for the various areas that the Behavioral Health Committee can be connected to and accounted for, and what we can support in all of this work. So and existing measure supports are things like the current work with the CCOs for the QUIP programs and helping to incentivize the work to achieve those things. Contract measures is another opportunity. These are measures or metrics outlined in various contracts and agreements that govern behavioral health services, and seeing if we can make sure there's some contract measures that have some standards and accountability, that there's a contract obligation to report back out to us, not in a burdensome way, but in a way that demonstrates that we're working towards those foundational goals of improving access, other kinds of things. And then bucket 3 are measures that are not yet created. Many of you know the measure sets are fairly standard. A lot of them have been physical health focused. And so developing behavioral health measures is something that is really important as we go further, really looking at what's upstream, what are the root causes, where are the community conditions that are influencing behavioral health. And while some of these might not be formalized, yet there are opportunities for us to really be at the forefront of making sure that we can develop measures that are really moving the system forward in preventative and long-term longitudinal care. Next bucket, please, or next slide. It is a bucket. In 2025, there were significant efforts made by the Behavioral Health Committee to really set some downstream metrics. And this was a formal vote that is a win, a major milestone for the committee, was putting forth a downstream metric and measurement that allowed, that was referred to Metrics and Scoring Committee that really will hopefully be included and could have been included. Timing might be an issue in the 2026 quality incentive measures. So this was a big step forward for this committee to really get some solid work established. Next slide, please. So in these, there's also been looking towards that second bucket, really some contract measurement. We've been working with Abby Stamp, who was referenced before, who's the executive director of the Measure 110 work. And she came in June to the Behavioral Health Committee to look at what are some guides to establishing some additional work with the Burns and others to be able to measure how we are working at low barrier substance use work, harm reduction, peer support, housing supports, and screening for health and social service needs. An additional step forward was in August, the community mental health programs. Dr. Collins and Marisha Elkins came to talk about community level programs that provide mental health services across Oregon, particularly some of the work that has really robustly been stepping forward to make sure that our community financial assistance agreements are really stepping into where the work is with people with serious mental illness, such as aid and assist, civil commit, and crisis services. And then the third bucket of work that's coming in this contract measures is this month. Dave Inbody and Dr. Emma Sando are coming from the CCO operations manager, and Dr. Sando is the Medicaid division director, to really talk about some of those integrated CCO measures and where the committee's work and this pocket of work potentially can align. Thank you. Next slide, and I'll hand it back to Ebony.
All right, so I know we did a lot of talking. We were talking fast, and so now we're happy to open it up for discussion and take any questions and feedback.
Great. Thank you so much. Looking to board members. I know I have some questions too, but Brenda, I saw you raise your hand. Would anybody else like to be next in the queue? Brenda, go ahead, but I'll keep an eye out for hands.
Thank you so much for the time today and the presentation. I'm struck by the complexity, as always, when we receive presentations like this, and I think about the layers of inputs and decision-making influencers in the behavioral health space overall. So if I'm looking at slides 28 and 29 and counting the numbers of councils, commissions, and work groups that are influencing and informing, I'm overwhelmed, and I'm certain you all are as well. I'm curious in terms of what, if you were dreaming, Ebony, I suppose this question is directed for you. If you were dreaming of a more simplified version where you were designing both inputs that had kind of advisory capacity and decision-making bodies, you know, where we were really empowering these commissions, work groups, councils, and the like to enact change. How would you imagine a more simplified version where decision-making is clearer in this very complex ecosystem that you describe? I've got a statement and a question in there, I suppose. You know? So I'm curious, if you were to redraw this map, you know, what would be most useful in your vision? Yeah.
Yeah, thank you for the question. And that's a complex question, and a question that has many layers and contingencies that have to be considered. You know, I think initially, what I think about is that, you know, a number of these various kind of tables, whether they're councils, advisory bodies, task force, commissions, you know, a number of them come from legislative mandates. And so, you know, I think that part of my dream is to look at, you know, how for every table, you know, going back and looking at the original intent to make sure that the table is relevant, because also, just thinking about where the current system is at in terms of being understaffed, dealing with the workforce challenges, dealing with kind of the complexities and the acuity of those that utilize our system, we know that a lot of folks actually are volunteering their time. And so what I also recognize is that when folks are serving at these tables, they're not able to essentially kind of carry out their day-to-day work. And so to me, again, it's how do we do our due diligence to make sure that, so this advisory body was established in 2015. Have we gone back and looked at the intent to determine if it's still relevant, or does it roll into another table? Is it time to potentially sunset it because it's duplicative? That focus is no longer a part of the system. So to make sure that I'm not rambling because I'm dreaming, it's, how do we assure alignment with intent, but then also thinking about the key priorities, rooted in the Governor's Behavioral Health Initiative, thinking about our goal around transforming behavioral health, and then thinking about just our efforts as a division to continue to, achieve continuous improvement in the work that we do in terms of the oversight system. I think that we really need to look at all those tables to assure that there's not redundancy, to make sure that, again, the tables really focus on present day need and policy, but then also looking at where can we streamline. I think the other thing is, another idea is, how do we also make sure that, my dream is to be able to eventually reduce some of those tables just for efficiency. But then how do we also make sure that each table and kind of their key charge also, again, is really rooted in, as I said earlier, our key priorities, governor's initiatives, and then, the core work that we've been charged with doing as a division. So that's kind of where my mind goes. But the last kind of disclaimer that I'll bring forward is that I also know that each table is nuanced, and so it can be easier said than done. But I think the first dream and step of action is just at least going back and looking at, like, what's the original charge? Does it make sense? Is there redundancy? Is there a way to streamline? And then going from there. And I'm not sure if that answers your question or not.
Yes, I see Dr. Hemming's hand raised. I just wonder if it's appropriate to encourage, and I don't know where my colleagues on the board stand on this question, but to encourage really clever strategic focus in this notion of alignment and streamlining. I'm thinking about the fifth pillar, about OHA's capacity to actually enact the changes that each one of these bodies are attempting to accomplish, and the administrative complexity for you and your team to administer and to make all of those connections. So just as one member of the board, strong urging toward simplification and alignment across a very, very, very complex structure. So I don't know where that would sit in your process of setting action plans that are connected to pillars and the specific strategies themselves, but a strong nudge toward this intention from my personal perspective. So, and anything we as the board can do to help offer that recommendation.
Thank you, Brenda and Ebony. Dr. Hemmings.
Yes, hello. Good morning. Thank you all for that presentation. I have a couple of questions. Who, I think I know the answer to this, but I just want to get it on record. Who is the strategic plan sponsors? What body is that?
Which advisory body?
No, no, several of you mentioned it was, I forgot what slide it was, in terms of the measures and that
Okay,
they
yeah.
were sent to the strategic plan sponsors. I think I know who that is, but who is that referring to?
So as Transforming Behavioral Health, I'm the strategic plan sponsor at the division level.
Okay, all right. Focusing on the slide related to transparency and accountability. Um, in thinking about accountability, and I saw the organizational chart, for lack of a better word, in terms of where this board fits in on that organizational structure. And maybe I missed it, but I don't recall that the global measures and the outcome measures that were implemented last year, that there was ever a presentation here to this board as a draft. These are the drafts, and this is what, we're considering in development around the global measures and outcome measures. Am I correct in that we did not, there was not a presentation to this board prior to those measures actually being implemented for 2025? I see you shaking your head, Kirsten. Kirsten.
Yeah, that's my recollection as well. What
Okay.
I recall is we did have some meetings where these global measures were presented, but I hear you saying were they presented as drafts for
Right,
input?
right. So that there could be input from this board, unless that's not our role. Where's the,
I
the question I'm asking is, as I'm listening to this, and I don't see a whole lot there except for the Behavioral Health Committee where there is any accountability related to this board. So, I'm just wondering, like, what is our role except for listening to these presentations after the fact of what has occurred. That being said, um, I had, I had a chance to look at the dashboard, and I, you know, I'm very much familiar with the risk factor surveillance system, which is very, there is an adolescent portion to that Oregon does not use, right? So all of these outcome measures and dashboards are specifically related to adults. Am I correct? Because the data source that you're using is specific to adults and adults who have telephones, correct?
I I would have to rely on one of my HBA partners to
Okay.
confirm that. So
Okay.
but I believe what you're saying.
Okay, right. So one of the things that I'm saying is if we know that as a state we have concerns around the mental health for adolescents, right? For young children, that is not captured in these measures because the data that we're using does not include that population. Also, the telephone numbers also have to be associated with an address, right? When you use this behavioral health risks, the surveillance. And so you have a huge segment of the population that's not included. And we know that there's always limitations to any data source that we use. And I'm just wondering, was there consideration as to how you would capture this information for your global measures and your outcome measures as it relates to those who are houseless? Because we do know that mental health substance use disorder is significantly impacted for those who are houseless. And the data source you're using probably doesn't capture that population. Um, the other thing I also noted, and as we think about what's happening around the CDC, and we know that the risk factor surveillance system comes out of the CDC, even though Oregon does get to, select certain measures that they use and can incorporate in that. I did note that there is an Oregon adult health study that is done online. Um, and there's a contractor, ICF, incorporated, and I was just throwing, it's about 3,500 households that complete this survey, this study. And, thinking about what's happened with the CDC, something to think about is whether or not, you know, there does ICF have the capacity to increase the study that they're using, because I believe that information is also combined with the results of the risk factor surveillance system, to actually give you the outcome measures that you're looking at. In terms of the dashboard, specifically quality of life around poor mental health, I noticed something really interesting, that the measures around the data for 2019 and 2021 was only available around race ethnicity for 2019, 2021, but there wasn't any data for 2022, 2023. We're now in 2025. Um, but it was available for disability. And I was just wondering, like, where is the data around race ethnicity for 2022 and 2023? Because you have it for disability, but you don't have it for race ethnicity. And also I saw that the measurement, the goal for 2025 is 4.7 days. And, I was just wondering, how did you come up with that number, to use 4.7 days as the goal, for 2025? And then I think it decreases by zero point 0.2 points each year, for your goals. And last but not least, the supply of licensed behavioral health providers. And I think I brought this up in a different venue before. And my question is, that number in terms of, you're using licensed behavioral health providers, and you're including providers who are not practicing. Now, for providers not practicing, they're not available, they're not accessible to the population, right? So why are we including providers who are not practicing, as part of that metric, which I believe your goal is to increase that by 5% for 2025, but you don't have a goal for 2026 or 2027? So those are just some of the things that kind of stood out to me, for what I was able to go through and review the dashboard numbers. So I yield back to Kristen. Thank you.
Sure, lots of questions in there. Claire, I see your hand up, and I'm not sure if you wanted to respond to some of these comments.
I'd be happy to. Ebony, is that all right? Otherwise, unless you wanted to provide initial response. Okay. I would say, Dr. Hemmings, thank you for all of those comments, and really appreciate looking closely at the dashboard. I think in particular, I would say on behalf of the Health Policy and Analytics Division, any questions like this that we have are really helpful for us to go back and make sure that we're presenting data in a clear and helpful way. I think the level of detailed questions will need time to go back and look at and provide a response, and we're happy to do so after this session. And I'll see if there's anything else that Ebony wants to add, but we're committed to responding, and just need some time given the detailed nature of your questions.
Great, thank you. And before I get off, my first comment around transparency and accountability, I know that it was, Ebony, you stated that Dr. Hoffey developed the global measures and the outcome measures last year. And I was just curious, has those measures been developed already for 2026?
Not at this stage, no,
Okay.
but yeah.
So it would be great, if we're talking about accountability and transparency, if those measures could be presented to this board, and I'm not the chair, but I'm going to put that out there. If those could be presented as a draft proposal to the board and kind of get our input, that would be a suggestion that I have.
Thank you. And I just want to clarify that those measures, the current measures, are, go through 2027.
Right,
but,
right, right. But I mean, yeah. But
but going
yeah.
forward,
Right. Yes.
all
Yes.
of your input is helpful and will be considered for sure. So thank you.
Thank you.
Ebony, go. I saw your hand up, Ebony. I don't know if you want to speak more. Okay. Oh, Brenda, go ahead.
Thank you. Just a follow-up. I'm thinking about this board and our committee's decision-making accountability. And so as not to confuse our role and responsibility, Ebony, I was thinking about slide 32 in the presentation, which speaks to the Behavioral Health Committee's goals. That we as a board were tasked to help support those objectives that you just described. And so back to my earlier comment and, influenced by Dr. Hemming's questions around what is the right place for this board to engage and what is our scope of decision making, and helping us kind of find clear line of sight for that specifically. Because I think under the Director Hothy's authority, under your authority, under, many other influencers that, and other legislative bodies that are being tasked to do specific actions, relative to the behavioral health transformation. I just wanted to make sure that we're staying in our lane, so to speak, and that those quality metrics and incentives as outlined in the legislation itself that we're focused on, and what our committee responsibilities are and oversight for this body of work as well. And so it's more of a comment than a question, I suppose, at this point, but perhaps board leadership can help us think through what is really ours to do for future agenda work and to track, our own performance and accountability as requested by the legislature. So thank you for that.
Yeah, appreciate those comments, Brenda. And I definitely think this finding our role, finding OHPB's role and an appropriate space will definitely be a topic at our retreat next month. And so I think we will dive into more into like where can we provide the greatest good and be effective. And so I think we'll continue to wrestle with this. Tony, go ahead.
Yeah, no, I appreciate that comment, Brendan. I have a similar question, and I guess I'm trying to track. I think I'm not certain that I'm entirely latched on to what we're reflecting on what measures versus under, like as mentioned, slide 33 versus the strategic plan and the action items. And I feel like there might be some overlap as far as what was being defined as action items for those measures. And I do appreciate Kristen us bringing us back to the retreat to explore where we can best serve and help support this work moving forward with attention to what our capacity is and where we think our best efforts can be. So, but I guess with that question, still a tiny bit confusing. I feel from my standpoint and in following all this, are we referring to so the Behavioral Health Committee helps support information for the definition of metrics that CCOs follow. But I think there is some tension, some questions of us having a purview and insight into the strategic plan action items. And I think a distinction needs to be made here with regard to those two.
I'll leave space in case any OHA representatives want to respond to that. Okay, if not.
I mean, I from my perspective, I will just say that from my perspective, I think there's concentric circles or, some type of through line. But I think from just a very technical perspective, and Claire, I don't know if you would disagree with me, but I think when we're thinking about the OHA strategic plan, those are independent of the Behavioral Health Committee. And at the same time, there's relevance, if that makes sense.
And this is Claire. I'm just happy to add that I know Dr. Hothi is planning to join a portion of your retreat. And so this might be a place to engage with her, not just specific to the behavioral health pillar, but to the entirety of the strategic plan. Again, as that's a kind of guiding document that's already been written and well, it's living in terms of updating measures and certainly aligning on our strategies and actions. I think the work that and support and guidance from the board that's really more I think critical is helping us to determine what those actions are that can complement what's already being considered, right? The strategic plan is kind of showing our homework, as it were. This is what we are planning to do. What's missing, where can we focus, how do we prioritize? And I think that's the kind of guidance from committees and boards such as this that's particularly valuable, given that the strategic plan is already set.
Okay. Thank you, Claire. I had two questions for our OHA behavioral health staff. Definitely appreciate talking about using the Behavioral Health Committee to provide feedback for the 2027 measures. I think that would be a great point to use the committee and their expertise on. So thrilled to see that. You talked about having already submitted approval for some process measures. I was curious what the timeline is between your submitting of those, and then them appearing on the dashboard and being public. So that's my first question around process measure timelines. And then the second, I was curious, there is a strategic plan element around workforce, and you do have a outcome measure around workforce. I was curious to hear a little bit more about where the behavioral health workforce work happens, that action plan, just thinking about the board and our other committees, including our workforce committee. Is there overlap that we as a board need to be thinking about in focusing some, how much of the Venn diagram is overlapping there, or where is the behavioral health workforce work happening? So two different questions. Happy to repeat it.
Sorry,
I can take
having
the
my phone volume. I will say, and just for your first question, and Claire, please, correct me if I'm wrong, but I want to say that early 2026 is the target date, but I don't know if OHA Director's Office has kind of finalized or determined any final dates, but I just know that from what I recall, and we're happy to follow up in writing, but from just off the top of my head, from what I recall is that, early 2026. And just in terms of workforce, Don, do you want to talk a little bit about workforce?
Sure. Yeah, most of our workforce efforts are happening within my area. Tim Nesbitt is the manager for that workforce program. And we've actually developed a really nice dashboard in cooperation with the Health Policy and Analytics group that we would love to show you at some point in time. Erin McCauley, who's on this call, and her staff helped us to do that. And it was noted that in the strategic plan, though, the workforce metric that's chosen is pretty high level, and it's meant to try and address all the various more specific efforts that are occurring under workforce, which were largely driven by specific legislation that's come out over the past 4 or 5 years. Um, and so in a lot of cases, that legislation has also identified the metrics and or outcomes that we're trying to track and be accountable to. So, but all that being said, there is a level of work that needs to be done within our workforce that kind of goes beyond just the specifics of the legislation that we've gotten and that have provided funding for us, and figuring out how to do that strategically and make it something that's not almost grant driven at this point in terms of our funding from the legislature, to being more of a permanent part of the solution that we're looking for in addressing the behavioral health workforce issue in general.
And I just also want to add that there is a behavioral health workforce talent council that is currently underway, where the First Lady is leading the helm, along with selected folks from community and OHA, to also kind of surmise all of the efforts to date that are happening, whether it's the work that we're doing across OHA, looking at, kind of current and past, legislative appropriations and impacts, thinking about just, the workforce needs, thinking about, considering kind of the role of, the various boards to really come up with a set of key recommendations in the next session, also around behavioral health workforce. So that's another place too where there's some strategy and prioritization going on around workforce.
Okay, thank you, Ebony, John, and Claire, for that information. I think especially because we're having workforce later on our agenda, it's on my mind, and it feels anyway, I guess there's a theme here of a lot of different kitchens, shall we say. There's many kitchens. And how are we seeing the big picture, the forest for the trees, and using all those funds and energy efficiently and effectively. Okay. Seeing no more hands, I'd like to thank OHA's behavioral health staff for joining us today. There are a lot of questions raised, and so also appreciate Claire and the HPA team and Ebony and the behavioral health team helping us dig through those questions and provide some follow-up answers. And we'll be in touch for sure. Thank you.
Thank you.
Great. With that, we will transition to public comment next. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It's one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that the time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual. It's not representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each member is given 2 minutes to share, and in the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. And please know that written and verbal public comments will be reviewed and discussed following each meeting by board chairs and staff to determine appropriate next steps. I believe we have one person registered to provide comments with us today. Colleen, there you are. Please,
Hi.
pulling up the timer, begin when you are ready.
Hi, my name is Colleen Ruland, and I'm the director of the Oregon Pediatric Improvement Partnership. The focus of my public comment is on behavioral health. We are deeply concerned that as Medicaid considers how to adjust to reduce budgets, and you all focus on addressing the gaps in the state behavioral health system, there is largely a focus only on high-cost adults and youth. While the federally required set of DT services as part of EPSDD remain unprovided. There is CCO reported and clinical service encounter data clearly demonstrating that there is not an adequate network of behavioral health providers to provide EPSDD services for children. The solutions proposed for achieving a more robust system for adults do not work well for low acuity children. In fact, recent policy shifts by the largest insurer of behavioral health in our state are likely to make this situation even worse for our insured children. In Oregon, the crucial context to consider is that since 2013, so for a dozen years, a global budget has gone out to CCOs on the basis of network adequacy. There are structural issues contributing to the lack of network adequacy. One, CCOs have little financial incentive to address behavioral health network adequacy for children, since the consequences of unmet EPSDD needs don't result in immediate high healthcare cost. Two, the downstream metrics that Metrics and Scoring is currently legislatively required to pick include metrics focused on behavioral health, but they are largely within the primary care and physical health system. Lastly, it appears that there's not enough mechanisms to ensure a global budget goes to children and their services. 3 opportunities for you to consider. 1, ensure that there's a robust state investment in behavioral health workforce specifically focused on upstream outpatient behavioral health services for children. This aligns with the Early Learning Council's recent discussions. 2, in support of the governor's directive to align health system metrics with the state health equity goals, consider working with policymakers to revise the current legislation requiring Metrics and Scoring to pick downstream metrics from the CHIP core set, given the gaps in metrics focus on the behavioral health system. And lastly, consider strategies in the next waiver in CCO 3.0 to ensure global funds earmarked for children are provided to child-serving providers in all 3 sectors, including behavioral health. Thank you for your time today.
Thank you. Are there any other public commenters with us today that are not ICMO related, which we will hear later? I don't see any messages saying they are, so I think that concludes public comment for us. We will take a 10-minute break. 12-minute break. We'll reconvene at 10:20. Thank you, everyone. People back into the room. I'd just like to welcome board members and meeting participants and everyone back into the room. We'll welcome back from the break. This is Oregon Health Policy Board September meeting. Next up on our agenda is the annual statutory requirement for the Oregon Health Policy Board to review and approve the Healthcare Provider Incentive Fund's proposed budget. Before the program's lead staff present the proposed budget, our fellow board member and liaison to the Healthcare Workforce Committee, Melina Moran, will open up this agenda item for us. And Melina, take it away.
All right. Thank you. Could you hear me okay?
Yes, we hear
Okay,
you.
wonderful. Thank you. So as the liaison, I'd like to introduce this. So the Healthcare Provider Incentive Program addresses the workforce supply and retention for patients experiencing health inequities through its provider incentives such as loan repayment, loan forgiveness, scholarships, and rural insurance subsidies. Program staff are here today to present the program's proposed budget allocation for the 25 to 27 biennium for the OHPB review and approval. This approval is legislatively required to take place before the Healthcare Provider Incentive Program can start spending its funding for this biennium, and is preceded by the Healthcare Workforce Committee approval that was done last month. These incentives should be familiar as the board approved the evaluation of the effectiveness of the Healthcare Provider Incentive Report this past June. And you will see some new data in today's presentation about the work that it was alluded to in the report, as well as detailed information about the administrative costs. So I am a practicing nurse practitioner, and I want to emphasize just how important these provider incentives are to recruiting and retaining a culturally responsive workforce and addressing access to care. I also would like to read a statement from the chair of the Healthcare Workforce Committee, Ian Strauss, as he was unable to be here today. So this is his statement. Chair, Vice Chair, and members of the OHPB, I wanted to take a few minutes to support the budget request for the Healthcare Provider Incentive Program for the 25 to 27 biennium. The Healthcare Workforce Committee has been ongoingly impressed with the information we received on the HCPIP and the increases in the numbers of providers affected and in the number of provider pathways that are being addressed. These incentives are fantastic tools for provider recruitment and retention, and this budget request clearly supports the continuation of that important work. I would also like to thank the OHA staff who, after our last healthcare workforce meeting where the budget request was approved, met with a group of committee members who had additional questions around the administrative cost. That discussion provided clarity on staffing, COLAs, contracting, and the source of the funding for those costs. That information is reflected in the presentation you're about to receive. Thank you for all you do, Ian Strauss, Chair, Healthcare Workforce Committee, Oregon Health Policy Board. And so with that, I'd like to hand it over to our presenters to begin the presentation. Thank you.
Great. I'm going to get us started. Hello, everyone. My name is Neelam Gupta, she, her pronouns. I'm the director of the Clinical Supports Integration and Workforce Unit at OHA, and it's within my team that the Healthcare Provider Incentive Program sits, and we're pleased to be here today. Next slide, please. So we're going to start by just quickly reviewing for you again the Healthcare Provider Incentive Fund and provide you with an overview. Also provide you with a timeline of the budget allocation approval process, what's happened prior to us coming here, and your role today. And then we also want to provide an overview of the Healthcare Provider Incentive Program, specifically the 2025-27 biennium budget allocation proposal, which we're here seeking your approval today. And then we will go through each incentive and provide a brief overview, as well as the rationale for the proposed budget allocation. We also want to, as Melina said, spend some time reviewing with you the administrative costs, answer any questions you have, and then we're hoping also we get to an approval vote as well. Next slide, please. So I'm going to start by providing you an overview of the Healthcare Provider Incentive Fund. Next slide. So the purpose of the fund is to help practices, professionals, and people. We hear often from healthcare practices as well as providers what an important recruitment and retention tool that these incentives are. Also, due to the high cost of education, it provides debt relief to those practicing professionals, both current and future. And lastly, it also helps to increase workforce diversity in local communities that benefit patients. Next slide, please. So just, this, again, this is going to be familiar to you because we were here in June, but just wanted to make sure that everyone had the same information. The Healthcare Provider Incentive Fund was started when the Oregon legislature passed the House Bill 3261 in 2017, which created the fund. That fund consolidated multiple existing incentives into a single pool, and it created the Healthcare Provider Incentive Program. And so the initial incentives were loan repayment, primary care loan forgiveness, Scholars for a Healthy Oregon, or SHOE, which operates at Oregon Health and Science University, or OHSU, SHOE-like scholarships, and then also rural medical practitioner insurance subsidy. And we'll be going more into detail on each of these later on. It also directs OHPB through OHA and its partners to every 2 years conduct a healthcare workforce needs assessment, which you reviewed and approved at your January meeting, and to evaluate the effectiveness of state financial incentive programs, which you reviewed and approved at your June meeting. And then we're here today because it directs OHPB to determine the best allocation of monies in the Healthcare Provider Incentive Fund. Next slide, please. So just wanted to review with you the budget allocation approval process and timeline. Next slide. So OHPB approves the Healthcare Provider Incentive Program budget each biennium. So for those of you who've been on the board for some time, this will be a familiar presentation, hopefully with some new information and data. And we have also come to you during the biennium, requesting adjustments as needed. And we do all of this based on the Healthcare Workforce Committee's recommendation. As you heard earlier, we presented this budget proposal at a special meeting of the Healthcare Workforce Committee in August and received their approval. The program is administered by OHA staff in the Healthcare Provider Incentive Program in collaboration with the Oregon Office of Rural Health, or ORH, as it's required in House Bill 3261. The fund and the program are under the policy direction of OHPB, and the fund allocation is required to be based on findings from the 2 OHA biennial reports, both the needs assessment and the evaluation of the effectiveness of healthcare provider incentive programs. Next slide, please. So as I mentioned, on August 13th, we did hold a special meeting of the Healthcare Workforce Committee to review the proposed budget. We did get approval, and thank you to Melina for also addressing that some members had additional questions. We met with them. They felt confident in the approval of the budget after we provided them with additional information, and provided a recommendation for approval to OHPB. And we're here today for the review, and hopefully the approval on that committee recommendation. And then once the approval happens, then the healthcare provider incentive program can begin spending the funds in accordance with the approved budget. So I will now turn it over to my colleague, Jill Boyd, to go through this next section.
Good morning, everyone. I'm Jill Boyd. I use she, her pronouns, and I'm the coordinator for the Healthcare Provider Incentive Program. And I wanted to share with you a little bit about the budget allocation proposal and some updated data from the last evaluation presented to you all in June of this year. That hopefully will help with the rationale and reasoning behind some of the changes to the budget from the last biennium. Thank you. Next slide. Okay, here we are. So this is kind of an overview of the proposed budget. Don't worry if we go through this slide quickly. We have this slide at the very end of the slide deck as well for additional reference. These are all the incentives that we are proposing to continue to support. You'll see that there are some increases to the proposed allocation in comparison to the 23-25 biennium. And I wanted to focus your attention down to the bottom around the total section. One thing we're doing a little differently in this biennium is we are proposing to utilize the interest earnings. So the Healthcare Provider Incentive Fund falls into an interest-bearing account, and we're looking to use the interest earnings for the administrative costs. And Neelam will go into greater detail in the administrative cost slides here in a little while. But I wanted to show that's part of the reason why we are able to use the full $26 million that was allocated through legislature is going to all of the incentives. There wouldn't be any of that $26 million that would be carved out for administrative costs. We would be using the interest earnings for that $4.34 million for the administrative costs. Another thing I wanted to pay a little bit attention to is specifically around the healthcare loan repayment incentive. This is for practicing professionals. We do loan repayment for those in primary care, behavioral health, and oral health providers across the state of Oregon. We're seeing a significant increase in that, partially based to incentive demand. We've seen overall an average of 40% increase in the number of applicants, not those that are interested in applying, but those are actually those that are eligible and have applied for the program. And then we're also including $900,000 for participation in OHSU's state loan repayment program match that's facilitated through the Oregon Office of Rural Health. And that's also included in that $11.35 million. And the Oregon Office of Rural Health did provide an overview presentation of SLRP, or the State Loan Repayment Program, it's a fun acronym, to the Healthcare Workforce Committee in May. And that information can be found on their website. Let's go to the next slide, please. Just as a little refresher for everyone about the Healthcare Provider Incentive Program, we've come up with this nifty little visual to kind of help to show where we're really trying to focus some of our impact. We really want to make sure that we are continuing to create some career entry as well as advancement, and then also focusing on the retention. These are kind of three of our cornerstone strategic directions that we want to be able to achieve within the Healthcare Provider Incentive Program. So you'll see that we have a newer program that we'll go through just in a little bit. It's called the Healthcare Workforce Pathway Scholarship, that's intended for students in middle school and high school who are interested in pursuing a career in the one of the healthcare fields. We also have the higher education. We have had primary care loan forgiveness for some time now, as well as the Scholars for Healthy Oregon initiative that's facilitated by OHSU. And then we also have the Healthcare Workforce Scholarship, which was rebranded. It used to be Showy Like, but we really wanted to expand the opportunities outside of the Showy programmatic protocols. And so we've kind of expanded that to include additional educational institutions to support not just physician associates and nurse practitioners, but also allied health professionals such as phlebotomists and dental assistants. We'll talk a little bit about that more in a minute. We also have a newer program that's the Healthcare Career Pathways and Retention Incentives, where we're supporting behavioral health workforce retention as well as healthcare interpreter retention. We also have our existing rural medical malpractice insurance subsidy, and of course, our most, I think, popular program is the healthcare provider loan repayment. So hopefully this will give you a nice little visual of how we want to be able to provide multiple opportunities to support healthcare providers across their career trajectory. Let's go to the next slide, please. So the first incentive I wanted to provide a little bit of update on is loan repayment. We're asking for an 11.35 proposed allocation for this, and there's some reasons behind it. But just as an overview, this is an award that awards practicing healthcare professionals with tax-free funds to repay up to 70% of their qualifying student loan debt in exchange for a service commitment at a qualifying practice in the state of Oregon. We have reintroduced behavioral health professionals and added dental assistants, as well as dental therapists, but we haven't had anybody apply as a dental therapist yet. They are as an eligible discipline in the 23-25 biennium, and we will continue to do so in the 25-27 biennium as well. The demand for this incentive, as I mentioned a couple slides ago, has substantially increased, and it does continue to grow. And as always, we're exceeding the applications exceed the available award amounts that are that we're able to offer. And in this last biennium, we were able to see that 36% of our recipients identify as people of color or from tribal communities. And that's something that we really want to make sure that we are supporting the growth and diversity of our providers as we make awards in this program. And you'll see we've added some additional data. In the last evaluation, it cut off at June 30th of 2024. So now we have some additional data to provide through the end of the biennium, which ended June 30th of 2025. So you'll see that while we really try to award as many individuals as we possibly can, the demand for this program has substantially increased, and we're only able to award with the amount allocated about 22% of those that apply. Next slide, please. However, with this increase, we're hoping to be able to award a few more individuals. Some of the adjustments that we want to consider for this incentive, again, this includes some matching funds through the Office of Rural Health's state partnership loan repayment grant application that supports primary care disciplines. This is a federal match through HRSA, and the intention is that we can stretch some of our loan repayment funds with that federal match program to be able to support those that are needing loan repayment in the field. We also are considering piloting some other high demand disciplines based on data from our previous needs assessment, outreach through community engagement, and just based on healthcare need that we're hearing from our partners across the state. So some of the rationale for the adjustment, we do have a proposed increase from $8.1 million that you'll see in the table below to $11.35 million. We've done, including our own evaluation report that's highlighted here in 2025, we are seeing that providers who participate in service-dependent loan repayment programs are more likely to work in rural and medically underserved areas, and they're more effective in retaining those providers and sticking around for a longer period of time. And you'll notice, we state that in our evaluation report, that 92% of our loan repayment recipients have been continuing to practice in Oregon even after service commitment ends, and that's up to a period of 5 years that we have data to confirm that information. So you'll see at the table below, we'll do this for every single incentive. We have all the way back from 2019, you can kind of see that the program growth over time and how many providers we've been able to award and what we're anticipating the number of providers that we'll be able to award in this biennium based on the increase of the $11.35 million. Next slide, please. Okay. This is primary care loan forgiveness. We're asking for a $1.1 million proposed allocation. As a refresher, this awards full-time students who are in an approved rural training track educational program to receive funding while they're still in school in exchange for a future service obligation. We've expanded this to We've expanded the number of educational institutions that have a rural training track. We've increased it to the nurse practitioner education program, Frontier University in the 23-25 biennium. So we most likely will see more applicants to this program as well in this next award cycle, which will begin in November. This is our only program, one of our only programs that focuses specifically on rural communities and make sure that those rural clinics have access to quality clinicians. And in our last biennium report, we had 27% recipients identify as students of color or from tribal communities. And as we did for loan repayment, you'll be able to see on the right side, we did update with our 2025 awardees since the evaluation cut off at 2024. So we have a little bit more of updated data for you where we were able to award 75% of the applicants for this incentive. Next slide, please. So we're requesting a little bit of an increase, and that's again kind of based on the demand of the program, as well as the additional addition to the additional educational institution with Frontier University. The adjustment considerations for this initiative, we're considering critical access needs in rural communities and the eligibility of healthcare disciplines and education programs. And I won't go over the rationale for adjustment. It's very similar to loan repayment. Again, those who are participating in a service-dependent incentive program are more likely to work in a rural area, and they're more likely to stay there. I do want to note that 89% of our graduated primary care loan forgiveness students who are practicing professionals have either remained at the same practice or in an equivalent practice site. So if they were at a federally qualified health center during their service obligation, they have shifted to maybe another federally qualified health center in the same area or across the state of Oregon. And you'll notice here that down in the table, we have the allocation amounts over time. So we've reduced it a little bit, and now we're trying to raise it back up a little bit in the 25-27 biennium proposed allocation, and just kind of highlights how many students we're estimating to award in this biennium. Next slide, please. This is the Scholars for Healthy Oregon initiative. It's another one of our incentives. Under statute, under ORS 348303, OHA contracts with OHSU to administer this incentive. It was established under a separate statute. SHOE provides full tuition and fees to OHSU students in exchange for service commitment at a qualifying practice site. And there is no change. We're not asking for additional funding since it's outlined in statute, but you can see here the information up till 2023. So we don't have the current information for the 2024 students yet. And I believe the 2025 applications are going to be going out this fall. Next slide, please. So again, there's a $5 million proposed allocation. There's been no adjustment to this request since the inception of this program within OHSU, but some adjustments for consideration for this incentive that we're working on is to make sure that we're improving the reports on the equitable distribution of the awards. We're learning a lot more about the program and how they're distributing those funds, and then also working with them to monitor the distributions of funds to ensure consistency with the health equity framework and REAL-D reporting guidelines. Next slide, please. So this is where things get really exciting for us. We really like to talk about some of the new scholarships that we have added. We have some career pathway scholarships and retention incentives, and we're asking for $5.75 million as a proposed allocation. These scholarships are intended to fund tuition and fees to support current and new incentives to help expand and diversify the healthcare professional workforce, particularly those who serve people experiencing health inequities due to lack of culturally specific and culturally responsive care. So some of the educational pathways and scholarships we're talking about is the Healthcare Workforce Scholarship. We have drafted in the evaluation report. It's formerly known as Showy Like, but we have rebranded to include a much more variety of disciplines and educational institutions in our scholarship program. The Healthcare Workforce Pathways Scholarship is intended to support secondary school participants interested in pursuing a healthcare career. And then we also are offering retention incentives. And currently we have 2 incentives to support healthcare interpreters and the retention of behavioral health workforce. Next slide, please. So again, we do have some information about Showy, the formerly known as Showy Like, or the Healthcare Workforce Scholarships in the evaluation report, but we do have some updated information in this table, which is very busy. I understand that. Just if you want to take a look just down at the 23-25 biennium, we're still kind of estimating the number of students that we're able to support through this scholarship incentive, since the scholarship is ongoing at this point in time. However, in the 29-21 biennium, we were able to award 14 graduate level disciplines. We had DOs, naturopaths, as well as physician associates. We then expanded in the 21-23 biennium to award 68 certificate and graduate level students. And then we were able to even expand further in the 23-25 biennium. We have 9 graduated students who are currently in their service commitment. 37% of the awardees identify as a person of color or tribal member. And in the 23-25 biennium, I did want to note that we are expanding to include behavioral health disciplines specifically. So we did have a subset of the awards within this scholarship that were focused specifically for behavioral health programs or training programs or training tracks that were focused specifically on behavioral health. Next slide, please. Thank you. The next scholarship I wanted to share with you all is the Healthcare Workforce Pathways Scholarship. Again, this is to support secondary school participants interested in pursuing a healthcare career. This is our first time doing this, so we were really excited to be able to award 6 pathways programs that are either focused on year-round support for students or summer programs, which have already been underway for students in middle or high school that are interested in a healthcare career, either in physical health, behavioral health, or oral health, or just health in general. We include these activities include kind of career exposure, mentorship, and for some of these training programs or CTE programs, they are able to earn certification like a medical assistant certification prior to graduating from high school. So these are all estimated numbers of awardees since data collection is currently underway, and most of the awards, aside from some of the AHEC programs, which did some MedQuest summer camps, most of the awards will be distributed in fall of 2025 to students. Next slide, please. And then just to share with you a little bit of the data that also, these are new programs that weren't in the previous evaluation. The healthcare workforce retention incentives, we have 2 of them. The first one is intended to support the retention of the behavioral health workforce by funding MACBO, or the Mental Health and Addiction Certification Board of Oregon. They're providing scholarships for registration and advanced exam costs. And this is our year 1 information that we received from them. We have a 2-year grant agreement with them to continue to support those that are wanting to either take additional exams or get registered for certain examinations in their field. The next program is intended to support healthcare interpreters. So this is, we want to provide continuing education training for healthcare interpreters to renew their certification, or if this is if they're a community health worker and they want to also become a healthcare interpreter, this program is intended for that purpose. And we have nine awardees. This was a non-competitive grant, so anyone that is registered with the state of Oregon as a certified healthcare interpreter training program was eligible to apply, and these were the 9 interested awardees that applied and were able to receive some funding. Next slide, please. So again, these scholarships that focus on career pathways and retention incentives, we're requesting $5.75 million as a proposed allocation. Some of the adjustment considerations is we're really wanting to expand the number and the breadth of the healthcare workforce scholarship training program with a broader outreach plan and continued focus on supporting diverse students. And then we're very excited to be able to continue and expand the career pathways and retention incentives in this biennium. We do have some information on rationale for this adjustment. We have some data from the National Conference on State Legislators showcasing that pathways incentives really do help students gain confidence and knowledge in the field, and over 65% moving into their field of study and graduate school. So we're really excited to be able to support students as early as middle school who are interested in pursuing some sort of healthcare career. And you'll see down here in the bottom table, the allocation we had in 23-25 was about $5.35 million. We do have some ongoing funding to allocate since we have a little bit of overlap. So about $4.98 million has been paid out of that 5.35, and then we're requesting a slight increase to that as we have a variety of different scholarships within this pot of funding to hopefully support over 2,500 students. Next slide, please. And our final incentive before we get into the administrative costs is the Rural Medical Practitioners Entrance Subsidy. This is a $2.8 million proposed allocation. This is one of our longest running incentives within the Healthcare Provider Incentive Program. It was launched under House Bill 3630 in 2003. It provides partial malpractice premium subsidy payments with a focus on obstetrics, pediatric, and neurology specialties. And it's originally intended to support independent providers that were not intentionally supported by a clinic or a health system. Many providers are now receiving malpractice insurance through group coverage, so we have seen a bit of a drop in this incentive over the years. And you can see the table on the right talks about the percentage of professionals that we support based on their discipline. We do reimburse them 80% of their yearly rate for those that are providing that are doctors, nurse practitioners that are providing obstetrics care. So we have seen a bit of a flip. We have more providers that are in general family practice, general surgery, and then 15% of those that are not included in any of the above, but still would like to receive some incentive from this program. Next slide, please. So because this program has been pretty stable for several years, we're not requesting an adjustment to the proposed allocation. It's going to stay at $2.8 million. We have seen a gradual increase of provider participation, but we have heard from you all, from providers out in the field, that long-term provider investment to support the recruitment and retention of practicing professionals in rural areas of Oregon is important. And this is one of those incentives that supports that. So we want to be able to continue this program as well. And so we can see here that even with the no changes in the proposed allocation, we still hope to serve between 400 and 450 participating providers in this biennium. And with that, I'll take you to the next slide and move you. I'll turn it back over to Neelam. Thank you.
Great, thanks, Jill. We're gonna spend some time now on the Healthcare Provider Incentive Program and administrative costs. Next slide, please. So what we have proposed is a cap. Our preference is to come to you today and not to have to come again during the biennium. And so this is, kind of a detailed explanation of this proposed allocation cap. The first area that you'll see an increase in is the intergovernmental grant agreement, or IGA, that we have with the Office of Rural Health. Again, this is required to work with ORH in House Bill 3261. And we are so pleased to be able to partner with ORH. They are amazing partners in this effort. And the reason behind this increase is to really support an enhanced workload through the expansion of incentives. And as you heard earlier, the reintroduction of behavioral health workforce incentives. All of that requires increased marketing and outreach, and particularly to make sure we are offering these incentives to people from diverse communities. We also really want to focus on improving our data tracking and management of the service commitment. It takes some effort to make sure we are staying in touch with providers, addressing any issues they might have during their service commitment. We've seen an increase in some of those issues over the last 2 biennia. And then also, similar to OHA staff, to address needed adjustments based on cost of living and inflation increases. And then the next area is to maintain program integrity within OHA, to continue to support data collection, particularly of real D data that has been a major success we had this past biennium in introducing real D data collection. Also the maintenance and upgrades of those systems. Then also continuing and strengthening strategies into our policies and procedures, contracting and invoicing, supporting grantees. You'll, as you saw in the earlier slides, the number of grantees we have, particularly with the introduction of some of the newer incentives, has increased. And then lastly, around metrics and accountability. Next slide, please. We also want to support our equity and community engagement initiatives. We really want to enhance our collaboration with community partners to implement equity-centered policy and programming. One of the best examples of that is our newest career pathway and retention incentives. We also really want to be able to reestablish a provider work group to have real-time advice on any program adjustments. And as we mentioned when we came for the evaluation approval, we have been consulting with an equity expert on how to reestablish this provider work group. And then the next area, which you'll see an increase in, is around the 2 legislatively mandated reports, the biennial assessment and evaluation. We really want to hire ideally 1 external evaluator to work with us to develop these 2 legislatively mandated reports. The healthcare workforce needs assessment, we really would like to involve the healthcare workforce committee in the conceptualization and development of the report so that they can feel very confident in the final product. So that's one of our considerations, and then also to maintain that strong link because part of the purpose of the healthcare workforce needs assessment is to inform the investment in healthcare provider incentive programs, also to have a strong evaluation. We really want to look for the first time because this is a report that OHA staff has traditionally done. We want to allow for an evaluation of the program's effectiveness in the context of national research and data. We would love to have a contractor to do like a really thorough literature review that would serve as the basis for us to measure and monitor impact. And then also to work with an evaluator who could develop a framework to better determine the efficacy of incentives. We are hoping that we could get an evaluator who could help us develop this framework, and that it would need to be updated periodically, and it would be applied to all future reports. And the timing to expand the budget costs in the 2025-27 biennium is ideal because, as Jill had mentioned initially, the Healthcare Provider Incentive Fund is in an interest. Those funds that we get from the legislature go into an interest-bearing account, and we do have interest earnings that are being used this biennium instead of the funds that the legislature allocated to us this biennium. Next slide, please. So this is then the detailed breakdown of the $4.34 million in estimated administrative costs. The first area in which we are requesting an increase of $0.26 million is in staffing and salaries. And that is due to an estimated union negotiated COLA and step increases. We also, during the last biennium, had added a manager position for 1 year of the biennium. And we would like to include that manager for the full biennium that we're currently in. Just the growth in interest in and demand in workforce incentives has required someone to manage the healthcare provider incentive program, really look at connections with our other incentive programs and also across OHA. So that is part of the reasoning for having the manager position in this for the full biennium. The second area is around contracts and agreements. It's a 0.81 million increase. This is due again to maintaining the ORH intergovernmental grant agreement, which we are required to have, with estimated union negotiated COLA and step increases. And just as a reminder, in the second half of the last biennium, we did add 2 FTE in the approved 2023-25 biennium budget. The agreement hits during the midpoint of the biennium. So you're seeing that full increase during this biennium. And then, so that's about 75% of this proposed $2 million. And then about 25% will go to these external contractors for the provider incentives evaluation and the healthcare workforce needs assessment. And we are hoping, it can be a one-time or periodic expense, but we will, that is still to be determined. And then other expenses, you will see that there is about a $0.3 million increase to specifically training, phones, shared services, IT, and office supply costs that our budget team has provided to us. And just as, one final reminder, this all is being allocated from the interest earnings. Next slide, please. I think you need to advance. Thank you. All right, so then, just to give you a sense of how the administrative costs have increased, as really the program has grown and evolved, and its workload has expanded. So, you'll see that, starting in the 2019-21 biennium, we had the 4 incentives that existed prior that were pooled into the program. And particularly, I'd like to draw your attention to what happened between the 21 and 23 biennium and the 2023 and 25 biennium. We really added disciplines in the 2021-23 biennium, and we added even more disciplines to loan repayment in the 2023-25 biennium. We added, education program, Frontier University, as was mentioned, to loan forgiveness. We also added education programs to our scholarships. We started the new career pathways and retention incentive, and we, were very successful with implementing Real D data collection. And so part of, the need for this increase is the continued implementation of those expansions we did last biennium, and then the ongoing needs of Real D data collection. And you'll see, all throughout, as we added on these new incentives, new disciplines, there was, an increased need for new marketing and outreach. The number of contracts we held also increased, and you'll see a pretty dramatic increase in the number of incentive recipients awarded. So those all involve additional tracking, providing technical assistance if they need to change sites. And then also, as we've, the interest in workforce has really grown following the pandemic. We've had to look to external contractors to help us with these with these legislatively mandated reports.
Neelam, can I interrupt you really quick?
Sure.
I do think that this warrants a lot of discussion, and we are running low on time.
Sure.
So I just wanted to give you a little turn up the speed just a little bit, please.
Yeah, this is the last slide. And then could you just go to the next one? Now we're at questions and comments. So yeah, I will turn it over to you.
Melina, I see your hand up. Go ahead.
Okay, great. Thank you. Thank you, Jill and Neelam. I just want to quickly say that obviously this program addresses the workforce in many different areas, the pipeline, the pathways, retention, and recruitment. So as a board, it's our responsibility to closely review and approve this budget. Um, I want to again point out that this budget was approved by the Healthcare Workforce Committee. And as one of our subcommittees, we rely on their expertise. But I would like to give OHA staff, either Jill or Neelam, just a moment I would just love for the record. I just want to ensure that there was a robust discussion within the Healthcare Workforce Committee regarding the administrative cost, because this was such a large jump from 11.7 to 14.3%, as we are relying on our subcommittee and their specialty. I just want to ensure that that discussion was had. Would you, Neelam or Jill, would you mind just giving us an overview of that discussion?
Sure,
Thank
absolutely.
you.
Yeah, thank you for the question, Melina. Yeah, we did have quite a bit of discussion and review of the administrative costs because, we are taking it from the interest earnings, and we also recognize it is a pretty substantial increase. And so majority of the committee members felt comfortable with the approval. There were 2 committee members in particular who had additional questions. One of the committee members was newer and just had some misunderstandings about whether the staff for OHA were new or existing. So we tried to provide a little bit more detail in this presentation. And then the other committee member had some questions, particularly around the external contractors. And we met with that person as well and provided, more information about how, there is a need really to understand the effectiveness and impact of the incentives, as well as, using this new process with the Healthcare Workforce Committee of really involving them from the beginning requires more resources. And so after those conversations, both those committee members were supportive.
Great, thank you. I saw Bill's hand, and then Brenda, and then Tony, I think. So we'll go in that order. And I do have some questions from Dr. Hemmings, who unfortunately had to leave early, but did share some thoughts in advance. So I would like to give voice to her questions as well as my own. And I do want to state for the record that I believe Peter is with us back.
Yep.
Great. Welcome, Peter. Bill, go ahead.
Thanks. And thanks, Neelam and Jill, for the presentation. I appreciate all the work the team has done in managing these programs. Healthcare provider incentive programs are very important for tool for addressing Oregon's healthcare workforce challenges. And I want to make sure the state's funds are being used for maximum effectiveness. I did notice that the administrative costs as a percentage of the total program expenses have increased dramatically every biennium. It was 5.1% in 2021. It's now 14.3%. That's on slide 29. The dollar amount is more than quadrupled over that period, from 1 million to 4.34 million. And the increase just from the last biennium to this biennium is 1.39 million, or it's a 47% increase over last biennium. I understand the program has grown, but usually when a program grows, the administrative costs decline as a percentage of the total, since some of the administrative costs are fixed, regardless of volume. So there should be some kind of economies of scale, if you will. But in this case, it seems to be the opposite. And my concern is that what's spent on administrative costs is not available for program expenses. You state that the administrative costs are covered by interest on the fund balance, but couldn't some of those interest earnings be used for program expenses, keeping the administrative costs at a more reasonable level and have it spent on actual programs for workforce incentives?
Yeah, no, thank you for the question. I really appreciate that. And I recognize it is a fairly substantial increase from last biennium. And I will say that the program has been really operational since May of 2018, so for about 7 years. And we've innovated and tried new things. I think we've come to the point now where we're going to maintain our existing incentives. And so our hope is that this is a one-time kind of high jump that we're experiencing.
I asked a question whether some of the interest earnings could be used for program expenses. We could use some of those for program expenses, and we have elected to use them for administrative costs. My understanding is that the Oregon Health Policy Board is also very interested in having us look at an external evaluator as well.
Claire, I see your hand up. I assume it's because you want to comment on Bill's question as well.
If I can, just for a moment, I think, and Neelam covered it to some extent, but I do just want to kind of reiterate a couple of things that have changed since 2019 or 2018 rather. The one is simply our increase in administrative costs. We need to keep up with our expenditures on this program. We also have our own contractors that similarly have increases in their administrative costs, and the program as it was originally designed didn't necessarily have the infrastructure that it needed to do robust community engagement and work with partners. And nor did it have the ability to focus on health equity as it does now. So there have been some additional program activities that have been added, significant program activities that have been added since the program first launched, which contribute to increased costs to operate the program. We've also, for instance, developed new programs. Neelam and others mentioned the Pathways program. So there have been additional programmatic costs related to expanding and designing those components of the program. We'll just also reiterate our interest in evaluation. I think that's continues to be an area that we're interested in and can continue to engage on that. But we do have costs to manage the program and need to find funding for that. And we are using the interest payments for that.
Okay, thank you. I'm going to go, Brenda.
Thank you. I'll just stay on the same thread and suggest perhaps that we consider an administrative cost modeling exploration that isn't quite yet represented here. So as the volumes increase, the number of recipients awarded has increased over time. I think that's a really important variable to consider as we think about the total cost and spend for the program. So just crudely, some early math on looking at the cost per recipient to administer the full program. We sit now at about $1,800 per recipient in this proposed, and last year it was about $1,700. The year, or the biennium rather, and the biennium prior to that it was around $2,100. The first biennium it was around $1,300 per recipient. And so my question is, as the total program funds increase over time, to Bill's comment about, we would think that some of the administrative costs per recipient would actually decrease, while I still appreciate the other kind of management and program expectations that have been laid into this. What I wonder about is what might happen when the total number of resources diminish, and what is our kind of threshold by which we would also then decrease administrative costs to administer the program. And so there's a little bit for me about like thinking more long-term about what the admin modeling could look like, such that it gives the staff and OHA some predictability about how to staff up or down. So Neelam, your comment about this may be a one-time sort of influx based on new program requirement. My interest would be in seeing, can we look at a trend line that's a little bit more variable to the outcomes that we're creating, which the easiest outcome for us all to look at is the total number of people impacted by the program overall. So I recognize the cost for each administrative element in the programs are not flat. You know, that some require a bigger, heavier lift programmatically to do than others, but I'm just wondering if we can back ourselves into a program model kind of rubric, for lack of a better word, that might help us stabilize this big question. And that I realize that by suggesting that we wouldn't be ready to act on this today. But I wonder if it's not better discipline actually to think about modeling it differently. Yeah, thank you.
Yeah, no, thank you so much for that comment, Brenda. And I recognize in the past you've also asked for kind of the cost per you know, person who goes through the programs. And so, you know, that I think that's a great suggestion and we'll take it under advisement.
Tony, go ahead.
Yeah, what a tremendous program. And just really appreciate the work that the whole team is doing, Neelan and Jill, thanks for the presentation. And I think just reflect upon the breadth and scope of the number of recipients and moving from traditional loan repayment to now what an expansive program. I'm really pleased to see that. And looking upstream, looking further at high school and looking at those entry level positions. And I think it's just really stellar work to see. I'm quite attentive to this question as far as administrative costs. And I wonder to the extent, maybe you could expand upon the external evaluator of the program. And I wonder if the pairing of like learning the intentions of looking at that outside evaluation to see how effective we are in these different areas, if that might have some pairing to this question of administration and efficacy in that. Do you think that might be part of that review?
We could definitely include that. Yeah, we could definitely include
I just wonder, yeah, looking at that might help support a broader look as we're looking, how are we keeping people here in Oregon? How are we allocating? I think the challenge here is I know that an allocation of funding for a doctor of osteopathic medicine or a medical doctor versus, you know, a $500 grant for somebody in high school, as far as the total funding with that, it is challenging to fit that all in. And I think the total number of recipients moving from, forget the exact number, but I think it was around 900, and now looking at 2,500 recipients is really, again, remarkable. But I think looking at a study of how is the program doing is really what I think what I'm hearing from colleagues here and what I would be interested
in. Thank you.
I would love to just, oh, Brenda, go ahead.
Oh, I just love what you said, Tony. I think that there's so much, and having been a liaison to this community, I've seen the power of this body of work. And to Melina, your comment earlier around how heavily the committee had weighed this issue that I think my colleagues are bringing up, and both like crediting the important work. And I know these topics can sometimes be really sensitive for folks, so I really appreciate the transparency and the level of pre-work that brings it forward for us as a group. I also don't want to stall the actual investment in workforce. You know, this is a priority for us as a board. We've named the importance of this program, I think, for quite some time. So my question is actually directed for you, Kirsten, which is around decision making for today and whether or not we could modify an approval process that basically asks for further examination in the administrative cost of the recommendations that the committee has put forward, and to think about doing, as I suggested, more analytical model review about what administrative costs over time will look like, and sort of to benchmark it against other programs. That would be the one withhold that I would say. Otherwise, I think the modeling that the committee has recommended for us in terms of the amount of direct investment for each of these specific programs could move forward while giving OHA staff some time to do the administrative cost analysis and bring that back to us at a future date for decision making. That's my proposed. I suppose there's a motion that could come out of that, but Kirsten, I'm curious if that works for you. And
Yeah. I guess I would love some feedback from OHA staff on the timing. Especially because we'd probably have that come back in December at our December meeting. No, November at our November meeting. And if there are implications, basically it would be like, great, yeah, funding sounds good, except admin, but then what if there are changes to that? And then like these programs have already been declared funding, but if you don't have the people to implement I don't know, do we get a little pickle there by separating them? But I don't know, Neelam or Tara Claire, any feedback on the timing here?
I mean, we can take this back to our budget team. I think this is, a unique area where OHPB has authority for approving a budget. I have some concern about setting a precedent that we would not have a budget reviewed a full quarter into a biennium. So I think that is a concern for me. We're unable to really operate under an uncertain operating budget for that amount of time, as I'm sure you all can understand. And so it would really be our preference to have this approved sooner than December. But again, I might need to check with our budget team on an exact date.
Are we able to approve part of this budget? Is what I hear the proposal on the table as.
I think that gets us into a tricky point given the status of the state budget overall and our need to have better certainty going into a rebalance request and short session. And so I do think that would be too late for us to have a full approved budget.
Okay.
I also want to declare just for the future, it also puts the board in a bad position to support your notion around making a budget decision midway through the course of the biennium. So I'm thinking from a calendar planning perspective for future boards that we think about anticipating this so that when we start the biennium, there's no confusion or sort of lag that you're anticipating, simply by calendaring the prep work for this action item in advance. So that staff and programs have adequate, you're not in this like last minute kind of a crunch. So earlier notice would have been helpful for sure, because I'm certain we could have gotten together and brainstormed possible solutions in advance.
I appreciate that. I think this is the timeline in which we are able to develop operating budgets. We are finalizing those for our division in particular by the end of this month. And so this is actually something that we've accelerated to be able to present to the board on a timeline that would give us the certainty and approval that we need.
It's a challenging pickle. Tony, then Bill.
Well, I wonder, could you offer just more information on the thought process on that external review and what that would look like and the timing of that?
Just to make sure I'm clear, are you asking about the external review of the administrative
effectiveness of the healthcare workforce fund?
Oh, sure. Yeah. So the external evaluator for both the reports.
Yeah.
Yeah. So we are just in the process of developing kind of a scope of work. We are meeting with the Healthcare Workforce Committee tomorrow and would love to get their feedback prior to developing that scope of work. Our hope is to identify hopefully a single contractor by the end of the year so we could get started with the reports in early 2026, both with the Healthcare Workforce Committee, and also we'd love to also engage the Oregon Health Policy Board to make sure that, you all feel confident with the reports when they come to you for approval in January of 2027.
Great, thank you.
Bill, then Melina, and then I do want to give some time to Dr. Hemming's questions.
Thanks. My understanding is that we're being asked to approve an allocation of the total budget. And if the question is around administrative costs, what I'm thinking is the decision might be potentially allocate some of what's being proposed for administrative costs and put it back into direct program expenses. So I would hope that the agency could proceed over the next 2 months with that kind of understanding, but the total budget's not for this program is not changing. And if especially since some of a significant chunk of the increase in administrative costs is for these external consultants, those expenses won't be starting up anyway until after the start of next calendar year. There wouldn't be any holdup or in terms of what could administrative activities over the next couple of months. So I would hope we could move forward as Brenda originally suggested, is approving the direct program expenses in the sense as a floor with a potential increase if there's some of the administrative costs proposed being reallocated to those direct program costs. That would be the change that we would consider in November.
Or since the admin costs are proposed admin costs are coming from direct savings too, that or from the interest-bearing account, right? They're not coming from the core budget regardless, anyway, there could be a mid allocation, reallocation, or wait and allocate later because it's not standing there. But Melina, go ahead.
Yeah, thank you. Yeah, I just wanted to, kind of point out what Tony was saying is I think a lot of our concerns and answers will come from that external contractors report, and a portion of these administrative costs does go to that report. And so my feeling is that I think it's important to go forward with the approval so that report can go forward with the timeline as Neelam was stating. I understand the concern. We could possibly do an overall approval with a different allocation. I'm not sure how that would look.
Yeah. I would like to. I have strong support for this external evaluation. I think it's needed. I think it's important. Even the board's role of determining best allocations of money in this program, I think is really hard to do without this report. Now we have a train on the tracks. It has to keep going. We're not looking to pull back these critical things that need to keep going in the meantime. But I do think that evaluation is so important to identifying what are the most effective paths to meeting the program goals. And I think I have more thoughts on the evaluation and making sure that it reflects the goals stated in slide 4, because I think we have different goals, right? And effectiveness can't just be defined based on kind of number of applications and demand for applications. We have defined goals here. And so looking for an external, I am in favor of an external evaluation to really help identify the most effective programs of that are out there. And when we think about how Oregon is allocating among these different programs, where are we getting the best bang for our buck, defined by our goals. And so I am interested in this administrative modeling, as Brenda identifies, and I think there's both ongoing admin costs and concerns about increases of those, and then there's this report that is in theory, it's not the regular maintenance on admin costs, right? This is a special project. And so if we did a modeling where that was removed and seen as one time or seen as irregular, like how efficiently are the admin costs of administrating these programs going over time? And then what does it look like in the future? As I hear Brenda requesting, like that kind of recognizes, okay, we have these one times. Are we going to continue to expect this trend of increase or no? So I wanted to underscore my support for this external evaluation, and I know that it comes with a cost. And I appreciate the ingenuity in having that come from interest-bearing account rather than coming from a core program. And I also think, given these nervousness or concerns raised and interest in the changes in administrative costs, that having this modeling done is of value, and I think we are clearly asking for that. I think there's a question to both for staff about how much can we approve budget? Can we approve this minus admin fees today? And then come back. We could do it. We have a special meeting at the end of this month. I don't know if that's fast enough for OHA staff to do some of this administrative fee modeling. We could do a special meeting, a different special meeting in October. If we can't kind of decouple these, or we approve the whole package, but then still ask you to come back in November with this administrative modeling. I guess first, OHA staff members, are any of those pathways off the board? Like not possible? Claire, I felt like earlier you were like decoupling's not possible.
Sure. I'm very quickly trying to get some offline advice from my budget leads. I mean, a couple things are external. Some of our external contracts are not up for renewal until next year, and so I think one option we would put forward is if we can seek approval for half of this first year, so that we at least have a budget that is known for this period of time. That would be helpful. I think that whether that's done in special session or now would be preferable. So I will stop there and see if Neelam or others want to correct anything I just said, as I'm trying to quickly make sure I get advice from the team.
Yeah, the only question I have is whether we could, I've also done some offline communication with their budget team, if we could proceed with the evaluation and needs assessment contractor solicitation, given that, in order to meet the timeline, we do need to get started in terms of looking for someone. So,
yes. And I do think, but the budget modeling that was originally proposed by Brenda, I think could be done by staff. And there might be a broader, like, how are other programs functioning, what like external evaluation for the future. Right. I think I'm interpreting that correctly, Brenda, that we're talking about a short, there's two asks here. One is more longer term in-depth comparison, and the other is a short term modeling using probably some different metrics of administrative costs and some projections.
I agree, Kirsten. I think just listening to the conversation, there are two distinct and different issues. They're somewhat interrelated, in terms of course, we want a robust program. We want to, expend the right amount of administrative costs to make that a robust program. So I think directionally, I think we're all in alignment and trying to find how to thread the specific needle that feels like we're taking our responsibilities seriously from a stewardship perspective. And recognizing the trade-offs that Bill referenced, which is for every dollar that we spend in administrative costs, technically we're not spending that in provider loan repayment or in other things that really, help strengthen and make the program so dang impressive. So I think my request is just to help you, Kirsten, kind of guide the next step would be to pause now and bring a full action back to the board in November, if that gives staff ample time to both consider the administrative financing modeling, recognizing what Claire said earlier around the interdependence between the administrative costs as well as the program goals. And so that would be my proposal, is to take no action today until the team comes back, and also to offer, I think we could stand up some small work groups, some calls, to support offline with the leadership, if indeed that's helpful to kind of nuance, I think, the conversation, make it more durable. I think in the long term, we want to invest in the right way, so thank you for that. That's my suggestion.
Brenda, if I can just offer, if we don't get approval today, it will delay the dissemination of some of the incentives. Jill, I don't know if you want to speak to that really quickly.
Yeah, so we loan repayment in particular is an ongoing rolling basis with the next wave, the next cycle of applicants closing in September. So we would need to have, so that would cause us to not be able, since we don't have an allocated or approved budget, we would not be able to make awards, which for that. So the next award cycle award we would be able to make is in March of 2026. So that would delay things significantly for loan repayment. Primary care loan forgiveness, the application opens in November for a January award date. So that would delay things again if the board's not able to meet and approve even by November. That would delay things significantly by at least 2 to 3 months, I would say. And then also the rural medical practitioners insurance subsidy. Of course, we would not be able to make Q4 of 2025 or Q1 of 2026 payments.
And that's if we don't approve today, or we don't approve by what day?
If you don't approve today, that's the delay that will be caused.
Yeah, so this is all new information. I think it goes back to Kirsten's earlier question of decoupling the administrative cost and the approval from the rest of the program costs. We don't want to delay, the awards for the recipients. I think that we've been clear. What I'm taking concern over is the major jump in the administrative costs. And so, Kirsten, given that I see Bill's hand is up, I bet he's ready to make a motion. And if not, I'll follow and happily help move us along.
Well, I think the intent of the board, from what I've heard in the discussion, is not to freeze or reduce any of the direct program expenses. So all the problems that Jill, you and Neelam talked about, there's no intent to stop those payments at all. So I think those should proceed. The concerns that I expressed and others have heard, I've expressed, are around the administrative expenses and whether some of those proposed expenses should be reallocated instead to direct program expenses. If anything, it'd be an increase in the direct program expenses over what's being proposed. That's all we're talking about. So I guess the motion would be something like this. If there's, I see Brenda nodding, at least generally, and the motion would be something like this, that we would approve the proposed allocation for the direct program expenses today, going forward, with the potential and that we consider potential changes to the administrative expenses that we reallocated to direct program expenses at a future meeting. And I'm okay with doing it in November, but if it needs to be October, that's fine too. Sorry, it's a long rambling motion, but the core is move to approve the direct program expenses as proposed as a minimum going forward, and consider the proposed administrative budget, reconsider the proposed administrative budget at a future meeting to be scheduled as soon as possible.
Okay, first I'm going to pause and see if there's a second on that.
This is Brenda. There's a second.
Okay, now let's have discussion. Peter, I see your hand up.
I wanted to offer Bill maybe a friendly amendment to make this a little bit cleaner, of approving the program costs as presented, but only approving the previous biennium's administrative costs pending a future meeting.
And I would
Is that
I would accept that as an amendment to the motion.
Second.
I just want OHA to have some assurity moving forward. At least there's something to start planning off of, and then after that, consideration for that raise. So just wanted to offer that and the thinking behind that.
Great. Thank you, Peter. Appreciate that. I saw some support from other board members for that proposal. So that is the proposal on the table is to approve direct program costs as proposed today and the administrative expense amount from the prior biennium with the and we will review additional increases to admin expenses at a future meeting of the Health Policy Board. Did I get that right? Okay.
Yes.
All right. So if there's not any additional discussion about that proposal on the table, we will move to a roll call vote.
Okay, I'll start with Tony German.
Approved.
Peter Starkey.
Sorry, coming off mute. I approve.
Melina Moran.
I am abstaining.
Bill Kramer.
I approve.
Okay, Brenda Johnson.
Approve.
And Kirsten Isaacson.
I approve.
All right, Dr. Hemmings is not present to vote, but we have 5 of 7 members voting to support. So
Great. Thank you, Tara. Thank you for board members, your creativity and work in getting that motion. I do OHA staff, Neelam, I think, and you don't have to answer this right now, but I do think we will want to work with you about when we could have you back and the board could have that follow-up conversation with that administrative cost modeling. And including if, we do have a special meeting at the end of this month, that is related to HICMO right now, but it is a special meeting of the board. So I assume that we could alter that to include this topic as well, if that was soon enough for your work. we could call a special meeting in October, or we have a regular meeting in November. And you don't have to answer that right now, but we should connect and see what timeline works for your group. I do have some questions from Dr. Hemmings that she did prepare in advance, and I do want to give some voice to those because though she may not hear it, her voice should still be represented. So if you don't mind hanging on a little bit, Neelam and Jill.
Sure.
Okay. Thank you. One of the questions that she asks is, and you answered part of this in your presentation. She asks if these are state funds only, and in your presentation, you did mention that some actually do receive some federal matching funds. She's asking if there were going to be, is the state going to be able to keep its commitment to awardees? Is there any signs of restriction or pullback on the federal level, especially if we have equity language that is included as part of these programs?
Yeah, I do want to make sure that it's clear that this is all state funding. It was, either allocated by the legislature or through for the administrative costs we proposed interest earnings. Jill, would you like to take the second question?
Sure. Yeah. So at this time, what we know today, that no changes have been made to any of the health programs that OHA administers, including the Healthcare Provider Incentive Program. And as always, we'll continue to monitor and prepare for and inform the public, as well as you all, if there's any changes that could impact the access to the healthcare and public health services that we provide in the state of Oregon. So.
Great. Thank you. And then is there data, particularly demographic data, on who was denied versus awarded or reasons for denials in the kind of application process?
So we do have data on that. I wanted to be clear because I hate the word denial, right? So we don't deny awardees. We're only able to award those that we have a pretty robust scoring rubric that we take a look at when we especially for loan repayment. I think is Dr. I'm assuming it's mostly for loan repayment. And because providers are able to reapply every cycle, and we have 4 cycles per year, there's oftentimes a good chance that they will get awarded. So it's not anything that they do or that they, so I was a little, so yes, we do have information on those who are not awarded. We do collect race and ethnicity, language and disability data for that. And I'm happy it's going to take a little bit of time to collect that information because not every applicant provides that information. So we're happy to compile that and publish that or send that over to the policy board at another point in time. But we don't have any, there's an essay question. So a lot of what we see from applicants is that there's maybe their essay questions are not fulfilling the response. Some people only write a sentence per response. And so it really doesn't get to the heart of that. We do, and in our partnership with the Office of Rural Health, we also work with the providers to, if they want to reapply, they know what they could do to kind of ramp up their application. And so that is something that we do offer as part of the technical assistance work that is supported through our partners at the Oregon Office of Rural Health as they work individually with some of the loan repayment applicants who are in their second, third round to make sure that they are providing the most accurate information and try to put their best foot forward for these applications. But to answer your original question, yes, we can provide RealD data on those who are not awarded at this point in time. And I can send that over whenever I can get that compiled.
Appreciate that.
Yeah, if I can just add, we would provide it specifically for our loan repayment and loan forgiveness incentives.
Right. I remember there's different data depending on the program. Great. Okay. Thank you for the work and your patience in your presentation. And we look forward to connecting with you again shortly and closing this chapter. But thank you so much, Neelam and Jill and Claire, for your participation in this part as well. We do have a last few minutes. We actually have some public comment related to HICMO that is important for us all to hear. Just as a reflection, at our August meeting, we asked OHA to solicit public comment on the HICMO Healthcare Market Oversight Program's Guiding Principles document prior to the board making recommended edits. So we do have some public comment to hear today. There was definitely some written public comment that was shared with all of us prior to the meeting. And then board members and the public are invited to 2 upcoming HICMO public comment listening sessions. I do want to flag those, September 12th and 18th. Tara will put some links in the chat if anybody wants to attend those listening sessions and how to register to provide comment. So following today's 2 listening session and then the 2 ones that we are invited to, OHA staff will compile all these public comments related to the guiding principles for OHPB members to review before our special meeting on September 30th. Okay, so without that ado, I will turn it over to public comment. We deeply appreciate public comments, one of those powerful ways we demonstrate our commitment to profound learning and listening. So we're gonna listen carefully, and I won't repeat the same spiel as before because we are short on time. I believe we do have 1 person registered to give public comment today, but I don't.
It's probably me.
Oh, hello, Mike Huntington. Welcome. Begin when you're ready.
Okay. Well, thank you for your extensive and collegial work. I really admire how you work together and for hearing our public comments. I'm Mike Huntington, a retired radiation oncologist living in a community that has been deeply affected by corporate buyout of healthcare clinic here. The current emergency exemption in OAR 409 070 0022 is so broad that clinics or hospitals facing financial trouble can easily argue urgent acquisition is needed, bypassing public review, transparency, and accountability. The Corvallis Clinic sale to Optum, United Health Group subsidiary, in 2024 illustrates the harm. After the buyout, many physicians left, service levels declined, and potentially thousands of patients lost access to care. These are outcomes that the exemption process is supposed to prevent. Similar disruption occurred at the Oregon Medical Group in Eugene after its Optum acquisition in 2021, with abrupt loss of provider access to patients. The rule's emergency criteria are vague and exploitable. For example, immediately threatens, quote unquote, or urgently needed to protect solvency, quote unquote, allowing distressed entities to justify exemptions regardless of broader community impact. The process can bypass public comment and effective review, leaving communities powerless and lacks requirements for enforceable commitments about provider retention or service continuity. We urge leaders to strengthen the rule by 1, precisely defining quote emergency unquote with specific financial metrics and requiring documented efforts at local remedies first. Number 2, mandating disclosure of transaction details, even in emergencies. Number 3, guaranteeing every exemption has a 3-month public comment period. Number 4, requiring retrospective review of patient access and provider retention within a year after the deal, and involving counties, advocacy groups, and workforce representatives in evaluations. Closing these loopholes is urgent to protect Oregon communities from unintended consequences of unregulated healthcare buyouts. Thank you.
Thank you, Michael. Appreciate your sharing your comments today and for the written comments that were also submitted. So at our meeting on September 30th, we will discuss all of the public comments, finalize edits or recommendations to the guiding principles for the HICMO program. We currently have 4 members confirmed for that special meeting, Peter, Bill, Tony, and me. It's really imperative that all 4 of us attend in order that we have quorum and are able to take that vote. If other members can make themselves available, deeply appreciate it. So that'll be September 30th from 2 to 3. And thank you for putting the listening sessions in the chat, Tara. And before we go, I do want to highlight our next meeting, our next full board meeting, long one, will be October 7th, 8:30 to 4:30 at the Portland State Office Building. Zoom participation will be available for anyone not able to join us in person. And looking forward to our retreat. And so it is 12:01. I won't say any more about our retreat, but really deep appreciation for the many hands that are making it happen. We are going to work with Clarice and Diana again, and there are individual board members who have been doing a lot of work to bring forward proposals on priority work areas, and deeply appreciate that. So thank you all for your leadership. Thank you all for your service. And we'll see you again shortly. Bye.